Okay, Atta, all set.
Okay. Thank you, John. Now, can I invite Professor Kenan Arnautovic from USA for his talk? So, thank you.
Just good afternoon. Can you see my screen?
Yes, put it on. Perfect.
And you can hear me.
Yeah, perfect.
Thank you. Thank you. So first of all, good afternoon. I apologize. I had to run over. I'm on call today for our main hospital, and my residents were doing subdural hematoma, so I had to run over. So I'm delayed by 1 or 2 talks. But nevertheless, first of all, I thank dear friend Professor Sameh Morsi Hassan for this beautiful venue where we meet every few months and discuss current topics. And I also appreciate, I saw a lecture of Dr. Shankar, a very nice contribution of Professor Yasergil and Suresh Dugani and all of other friends. So I'll start my talk with just briefly mentioning what has not been mentioned before. I landed in Little Rock, Arkansas, USA in 1993 as a war refugee. And at that department, when I entered, I met these people, but I was shocked to see Professor Yasergil sitting there. And of course, Professor Almefti was the chair, and Dr. Boop, Dr. Krisht. And then I learned that actually Dr. Yasergil has been retired in Zurich, and nobody offered him clinical position. He had few offers to practice neurosurgery as honorary president, to give lectures and so forth. But the only one who really went to give him lecture, other than lecture opportunity, to be clinical professor, was Professor Almefti. And little is known, and it has been written down in history, that there was a Dr. Ray Jouet. He was president of Arkansas Medical Board, and it's impossible to get a license to practice neurosurgery in the United States if you are not trained there. But Dr. Ray Jouet pulled some strings and convinced other board members in Arkansas, in Little Rock, to grant him this license. So everything else is history. So I don't do myself a service here. These are some of the residents that were there at this time. And you can see here, obviously, Professor Yasergil here, and you can see 3 initial fellows. I think probably most of you can recognize Dr. Ture and Dr. Borba. I don't know whether anybody can recognize me here, but it is what it is. Of course, this is a lecture, Professor Kurze, who was visiting us in Little Rock at that time. So Dr. Shankar mentioned a lot of professor contribution, so I'm not going to dwell into that. All what he has left to us in neurosurgery, including 330 publications, monographs, and trained, somebody calculated about 3,000 neurosurgeons. I'll just give you 3 personal issues, of course, his books. First of all, you know, what I learned from him on a personal note is this progressive length of bipolars, controlled suction, and progressive length and types of scissors that he uses. And I find it indispensable in my practice, and I love whenever I do this, I remember fondly of him. The other thing is, one day he called me to his office, and he was very, you know, hard and demanding a lot from us residents at that time, and I'm probably one of the or only resident here who was trained under him at that time, resident, of course. And he called me to his office, and I say, hey, I want to tell you something. I said, what's that, professor? He said, do you know that we are 7th-degree relatives? His grandmother was from, father's mother was from Sarajevo, and she's sister of my great-great-grandfather or something like that. And he gave me this book 4B, and he put there to my relative from Bosnia and so forth. So I hold this book especially important. The other thing is, you know, they would frequently call me out of the OR and say a few things to close. And I loved and hated it. I hated it because I was leaving clipping an aneurysm, but I was closing for him. And this is basically pictures, graphs that he cartoons draw for me, so I can dictate this surgery. So I'll treasure this for forever. I'm going to talk today about tuberculous cell meningiomas, things that's very dear and close to my heart. And as probably you don't know, I published a lot on the subject. And we all deal with these tumors when we are in our daily practice, different sizes and patient who present to us. But first, let's say, what is the goal of tuberculous cell meningioma surgery? First, we need to remove the tumor, hopefully completely, preserve the vision and improve it, have pituitary gland preserved, neurological status preserved and improved, all the vascular elements preserved, 0% CSF leak, 0% utilization of lumbar drain, 0% loss of smell or nasal discomfort. So which tumors cause lesions and lesions cause decline in vision? You can see a long list here, but tuberculous cell meningioma is among the leading. And how do they do it? Either direct compression or vascular impairment or combination of both, we don't know. One thing that we know is that optic nerve has two main segments, cisternal and orbital, that is connected with falciform segment in the optic canal that is kind of bridge between intracranial and extracranial part. What we don't know also exactly how many people improve after surgery, how many people worsen after surgery of tuberculous cell meningiomas, because in our studies that people publish, and we are currently working on my series to try to be as scientific as possible and educate ourselves and our patients, what can we expect in postoperative course. So as I said, all the studies that are published, only fraction are tuberculous cell meningiomas, studies of paracellular tumors. And obviously, only fraction of them have 2/3 of them have gross total removal. And then, of course, you know, there are so many other different lesions in this area. So, as I said, visual loss outcome, visual field outcome, visual acuity outcome is just about 50% or slightly above 50% of time reported. So again, we don't know exactly what depends, what are factors influencing vision improvement. Is it preoperative visual function, condition of optic nerve and retinal cells, size of the tumor, type of the tumor, and so forth. So when I looked into the vascularization of optic nerve, I found this article from Weinstein that the mean optic blood flow in cats was measured to be 50 in the proximal part, in the distal part of the optic nerve, intraorbital part, but only in proximal part, 13 milliliters per 100 grams per minute. So it's about 4 times richer blood flow distally than proximally in the optic nerve. So we first did this study to try to find out the vascularization of optic nerve, to trying to find out the pressure within the optic nerve and what happens when we release parts of the optic nerve tethering. And what we did is on the cadaver study, we did first open the cisterns, open the falciform ligament, and did anterior cranioidectomy to release the optic nerve and measure the pressure and opticocarotid distance. And we use this very, very efficient manometer measuring pressures, as you can see here. And what we found is that once we release one segment after the other, so it means cistern, arachnoid membranes, falciform ligament, optic canal, clinoid, the pressure comes down and the space between the optic nerve and carotid artery increases. So what we try to do is create certain steps, important landmarks, what should be done in order to make the resection of tuberculous cell meningioma safer, and the pressure within the optic nerve relaxed, and the vascularization within the optic nerve improved even before we start resecting the tumor. So stage 1 is 4 steps: cranioorbital craniotomy with pretemporal approach, removal of the roof and lateral wall of the orbit, opening of superior orbital fissure, and opening of the lateral wall of the cavernosa sinus. And you can see here all the steps kind of in the cartoon, and cadaver dissection. You can see after pretemporal approach, lateral wall of the cavernosa sinus is peeled off and cavernosa sinus opened. And I love to use gel foam powder to eliminate bleeding from the cavernosa sinus. So as you can see here, this is the craniotomy part. And then you can see here, Dr. Sanjeev also presented this in details, peeling, and I'm not going to dwell very much on this. And then we have stage 2, which has 4 steps, which is extradural removal of the anterior clinoid, opening of the optic canal, falciform ligament division, and opening of the arachnoid cisterns. And we all learned this from our mentor, my mentor, Professor Al-Mefti, who taught us how to extradurally remove the clinoid. And you can see here in the cartoon how we have to do 4 steps in order to completely release optic nerve before taking the tumor out. So here is just a quick view of these steps. Obviously, this is after pretemporal approach and craniotomy. We proceed with dissection of the clinoid. You can see here drilling with copious irrigation of the clinoid, and then using microsurgery. You can see here stump of the meningoorbital artery, and then going and slowly opening the optic canal, both from proximal aspect and from distal aspect. And then eventually mobilizing the clinoid and removing it extradurally. As you can see here, the clinoid is right on the surface of our dissection. So now, after that, we complete the optic opening of the canal. You can see here this trick I learned from Ali Krish for internal retraction of the dura, where the dura is retracted with this simple stitches. And you can see here opening of the optic canal upon removal of the clinoid. You see here the remnants of the canal are opened, and optic nerve completely dissected even before we resect the tumor, 360 degrees. Every piece of bone below, medial, lateral is completely resected and optic nerve freed. And then here is optic nerve, as you can see, completely under no pressure. And then the last part is opening of the arachnoid membrane. As you can see here, opening of the carotid cistern, opening of all these adhesions that tether optic nerve and keep it under tension. And opening of the sylvian fissure also here. And then at the very end, opening of the falciform ligament. You can see here optic nerve completely freed, but we need to open falciform ligament before we start doing the tumor. And here is opening of the falciform ligament. There are several ways to do it. I like to do it with an 11 blade and the hook. You can do it with scissors, and other options are also available to lift it with the pickups. So I'll just present few cases, illustrative cases in my series. This is a lady that presented with bilateral blindness for about 3 weeks. She had 0 vision on the visual fields, just was counting fingers, but no vision in US. They call it legally blind patient. And I told the patient, there is no way we can restore vision. In my opinion, we'll try, but after 3 weeks of complete blindness, it's probably not going to happen. And again, I already showed you this pretemporal approach, cranioorbital pretemporal approach. I'm going to quickly go through this part. Opening of the periorbita, roof and lateral wall of the orbit in the posterior part, or doing full cranioorbital zygomatic approach, depending on the size of the tumor angle that we need to attack. And then here is basically freeing the optic nerve, devascularizing the origin of the meningioma before we even start removing the tumor over the optic nerve. And then basically starting to remove the tumor, attacking it at the area of adherence. Here is opening of the falciform ligament, and then working above and below to remove the tumor. You can see here working between the two optic nerves, debulking and then identifying the contralateral optic nerve here. And you see that both optic nerves are not under any pressure now. And then finally resecting the tumor, the last parts of the tumor. And here is the final picture. As you can see here, here's the pituitary gland and stalk. You can see here optic nerve. And then a closure working below the brain enclosure of the dura. This patient surprisingly completely regained her vision on the right side and almost completely on the left side. Another patient, I'll show you also this lady, young lady with visual field cut, tuberculum cell meningioma. This is cranioorbital, relatively small cranioorbital flap. And then once we open the dura, not much is seen until what Professor Yasergil taught us, release the CSF. And then we start seeing more and more. The more you look, the more you see, the more you see, the more you know. And here is basically opening, showing optic nerve on the left, optic nerve on the A1 and internal carotid artery, coagulating the tumor, and then eventually going to the ACOM, going to the contralateral A1, devascularizing the tumor, and then eventually we are going to deliver the tumor. Here is almost completely devascularized and removed. And here is the final anatomy picture. You can see here optic nerve on the left and right. Here is the pituitary gland, pituitary stalk, perforators, and basically complete anatomy is visible. Another case, in the interest of time, I'm not going to show the video, but the same result, significant visual loss before surgery, and somewhat improved vision on the right side and roughly the same on the left side. Another case of tuberculum cell meningioma where we have very dense bitemporal hemianopsia, even going to the other side, and you can see postoperatively improved significantly with gross total resection and always preservation of pituitary stalk and pituitary gland. Another case, same story. On the left side, we have significant visual field loss, gross total resection, preservation, and improvement. Another case, again, gross total resection. Interestingly, you know, I found this patient's CT scan in 2001, and to the best we can tell, in 2001, she did not have tuberculum cell meningioma at that time, and she had a sizable one about 20 years later. So they do grow fast, you know, obviously, according to this case and other cases, and this is interesting finding. Another case here you can see pre and post-op. Another case now, if the patient has been previously operated and if the patient had previous gamma knife radiosurgery, this one, It is not, even when I did all these maneuvers, two stages, 4 steps each, I could not completely resect the tumor because the tumor was very adherent to the internal carotid artery and optic nerve. So you can significantly debulk, but second and third time, it's not possible. So first time is the best and only time to achieve cure. Another case, and this is the last case, I'll finish here in the interest of time. This is a patient operated in a very, very famous center in the United States, Calbay Center. And this was in 2016. And then she presented in 2017 with, she was blind, but she was losing even vision, light perception and waving discrimination. And when I looked into this, I found that they did not remove the clinoid at that time. And they did a difficult part, dissecting the tumor of the, carotid arteries, but they didn't remove this tumor that was compressing the optic nerve. You see the small piece of tumor. And to me, I knew that it's not going to be a difficult case because I went through the cranioorbital approach, removed the clinoid. As you can see here, there is no more clinoid, and then resected completely the tumor and preserved whatever was remaining vision. So in conclusion, I can say that I think that cranioorbital pretemporal microsurgical skull-based approach is the approach and technique of choice to remove tuberculum cell meningiomas, in my opinion. Thank you very much. And again, Samek, thank you so much for invitation.
Thank you, Professor Kennan. It was a wonderful talk. And thank you for sharing your personal and tuberculum meningioma experiences. It's one of the most challenging area to operate. Any questions for Professor or any comments?
I have one question.
Sure.
Yeah, excellent talk, Professor Cannon. I just want to know, depending on the involvement of the vision, which side you approach this tumor, whether you always go from the right side or on the side of the very worst vision.
So, tuberculum cell meningiomas are usually midline located. They sometimes go and overflow the carotid artery and optic nerve to the contralateral side, but usually it's fairly symmetric. So I also investigate the vision on both sides. If there is equal distribution or loss of vision, I tend to go from the right side.
Right.
But if the right-sided vision is completely preserved, for example, in hypothetical situation, and the left side is significantly impaired, in that cases, I would go from the left side. But as a general rule, I like to go from the right side, although technically there is no difference in approach. And as you saw, I do this approach below the brain, way forward. We are not touching the brain, barely do any retraction mostly with our suction tips, which is controlled suction, as I showed at the beginning, which Professor Yasergil taught us. So right side is a general preference, but occasionally I go from the left again, depending on the situation and on the visual loss.
Thank you.
Thank you. Any other comments or questions? Okay, so now our next speaker is Professor Omid Araglum from Ankara University, the famous pediatric neurosurgeon and very experienced from microneurosurgery.
Hi, dear colleagues. Can you see the slides?
Yes.
Yes, Professor.
Okay, first of all, I would like to sincerely thank Dr. John Bennett and Dr. Sami, for their kind invitation. It's a great honor for me to be invited and to take part in this meaningful event commemorating the great neurosurgeon, Dr. Gazi Yasergil. What he accomplished was nothing short of a revelation in microneurosurgery. His pioneering of use of the surgical microscope and the foundational steps he took in developing microneurosurgery have changed the field forever. In Turkey, we learned a great deal from him. In fact, the surgical microscope was first introduced in Turkey at Ankara University Department of Neurosurgery, thanks to his influence. So for many years now, I've been performing surgeries using supraorbital keyhole approach in my clinic. Our center holds one of the largest and most diverse case series in the world using this technique. Due to our limited time today, I will proceed by showing videos to illustrate key aspects of this approach. In this approach, preparation is critical, it's curious. I don't give intravenous fluids preoperatively. We administer 1 mg/kg of steroids, especially in ruptured aneurysms, to support vessel wall stability. Except in lobar hematomas or large interaxial tumors, I perform lumbar puncture in almost every patient. This creates an extra space between the frontal lobe and the dura. Then I position the head according to type and location of the lesion. Rotation and hyperextension are essential. No eyebrow shaving is necessary. Then next, the supraorbital notch should be identified by palpation. The skin incision should remain lateral to midline in this way, and it should extend as far as the McCarthy keyhole. Let's continue with a few examples. This patient presented with severe visual loss in both eyes. She had a endoscopic transnasal surgery at another center, but the tumor nodule remained and the cyst had grown. One of the most important steps in this approach is drilling the orbital roof and inner table of the frontal bone. And it provides extra anatomical space. The first goal is always to identify the optic nerve and carotid artery, internal carotid artery. CSF drainage provides excellent brain relaxation. As you will notice, we don't use any retractors. After draining the cyst, we excise the lesion from the interchiasmatic space and the optic carotid system. If possible, the removal of the craniopharyngiomas in the first surgery is crucial. Then I open the lamina terminalis to find the nodule, to reach the solid nodule. This case, I think, then I excise the nodule. I think this case beautifully demonstrates the reach to supraorbital approach. As you can see, now, as you can see, the entire whole anterior circulation, bilateral optic nerve, chiasm, lamina terminalis. And we can see all these structures without any retraction. This patient had multiple aneurysms. When I need to access the sylvian fissure, I use the monkey tail incision. The monkey tail incision is a modification of the keyhole approach, supraorbital keyhole approach. The first step is always to identify optic nerve and the carotid artery. I use often sharp dissection. Now we can see optic nerve and the right carotid artery. Sharp dissection is critical here, especially of the arachnoid bands over the optic nerves and the carotid arteries. CSF release gives us extra space, you can see. Then I approach to distal anterior cerebral artery aneurysm. After the proximal contour, and after the dissection of the aneurysm dome, I clip the distal anterior cerebral artery aneurysm. Not giving fluids and performing lumbar puncture offers a big advantage here, you can see. Now, I follow the right A1 to find ACOM and contralateral A2. Now I can see contralateral A2, contralateral A1, ipsilateral A2 and A1. I find the anterocomical aneurysm on the lamina terminalis. Then I open the sylvian fissure in the classical microsurgical fashion to find the MSA bifurcation aneurysm. You can see I use sharp dissection. You can see internal carotid artery, A1, M1, and I clip the MSA bifurcation aneurysm. This is another case. This is a patient with a giant olfactory groove meningioma. These are still widely approached via big bicranial incisions. However, using the supraorbital keyhole, we can remove even large tumors after drilling orbital roof and inner frontal table bone. I'm trying to find optic nerve and internal carotid artery. I first resect the tumor tissue overlying these structures. Once they are seen, I proceed to debulk the mass piece by piece. Now we can see optic nerve and we can see carotid artery. Now we can follow A1. Yes, we can now see optic nerve A1. Now we can follow the A1. I resect the tumor piece by piece. Now I see the chiasm, the contralateral optic nerve. Now I try to find contralateral A1 and anterocomical segment. Now we can see anterocomical segment. We can see ipsilateral A1, ipsilateral A2, contralateral A1, A2, and bilateral Herpner artery. Now I cut the forks to access the contralateral tumor. Again, you can see no retractors are used. We can see all circulation. and total excision was safely achieved. This approach has no age limit. I use it in both children and elderly patients. Don't be afraid of opening this frontal sinus. It can be easily reconstructed. After drilling the orbital roof and the inner table of the frontal bone, I open the dura, C-shaped fascium, and the first target is always optic nerve and internal carotid artery. Now we can see optic nerve, we can see right carotid artery. I use sharp dissection for the arachnoid bands. I cut all arachnoid membranes, layer the optic nerve and carotid arteries. Now we can see A1 artery. I use always sharp dissection. Now we can see the contralateral optic nerve and chiasm. Now we can go to the lamina terminalis. I open the lamina terminalis to reach the tumor. The tumor can be seen now. The patient's final diagnosis was a Langerhans cell tumor. As shown here, this approach allows access to anterior third ventricle lesions as well. Unfortunately, techniques like gamma knife and interventional radiology are pushing microsurgery aside. Interventional radiology and like gamma knife procedures kills the microneurosurgery. No patients wants large surgical scars, long procedures, or extended hospitalization anymore. Minimal invasive does not just mean small incisions. It means reaching your target via the safest and shortest route. This is an unedited video. This is a ruptured ICA aneurysms, and you can see in this video a ruptured ICA aneurysm clipped in just 15 minutes, skin to skin. Just 15 minutes. It is an unedited video. Most of the aneurysms I operate on in my clinic are completed with under the 30 minutes, skin to skin. You can see I perform aneurysm clipping 7 or 8 minutes after skin incision. It is an unedited video. After the 7 or 8 minutes after the skin incision, I perform aneurysm clipping. We must defend ourselves against endovascular or oncologic overreach, and we can do this only with refined microneurosurgical techniques. I always use ICG fluorescein and Doppler to check the vessels. And I always open lamina terminalis to prevent late hydrocephalus. You can see I never use any retractors. Recently, we organized a cadaver course on suborbital and transorbital keyhole approach, and we will hold another international live and cadaver course this October. Once again, I extended my sincere thanks to Dr. John Bennett and Dr. Semeh for their gracious invitation. Thank you.
Thank you, Professor Amit. Thank you for enlightening.
One question,
experience
sir.
you showed.
Sure. Sir, yeah, do you use, sir, lumbar drain in all your cases for relaxation or opening the
No,
system?
just lumbar puncture.
Puncture. Lumbar
Just
puncture for all the cases.
Yes, and then I open the lamina terminalis in operative.
Okay.
Yeah.
That gives a very good relaxation.
Yes. Yes.
So without opening the lumbar drain, without lumbar puncture, the relaxation wouldn't be that nice by just opening the lamina terminalis. Or that the lumbar puncture gives addition.
I think opening the lamina terminalis is enough for this.
Okay.
Okay.
Thank you.
Okay, I'd like to make a slight announcement. This is how the good old surgeon, this is how the digital world works. I was talking to Amit before the conference, and he said to me, let's do a robotics series at the beginning of August. I said, great, 2nd, 3rd, and 4th, because Umit's done, he did a series on microneurosurgery. So we're looking forward to his conference at the 2nd, 3rd, and 4th of this month. Okay.
Thank you.
John, John,
Yes.
please upgrade Sabino and Paulo Furili for panelist. Sabino is next. Okay.
Okay. Whatever you said, Sam. Oh, there you go. There you go. Another course. Very good. Athos, back to you.
Okay. So our next speaker is Professor Sabino Luzzi from Cesare, Sardinia, Italy. Please, Professor, the floor is yours.
Umit, you need to get off the screen there. There you go. Okay. Okay, Atta, what are we doing here? Hello, Atta?
Yes, we are inviting Professor Sabino Luzzi from.
Oh, okay,
Italy.
okay. I'm sorry. Let me get on that.
Oh, I thought you were already lined up. Professor Sabino Luzzi from Sardinia, Italy.
Dr. Luzzi, correct?
Sabino, yeah.
Sabino Luzzi, yes.
He's coming in. Come in.
Finally, can you hear me?
There he is. Yes, welcome.
Sorry about, but you know, I was not in the panelist. That's the reason why I'm delayed. Thank you so much. Can I share my screen?
Yes, please.
Thank you. Do you see my screen?
Not yet.
Not yet.
Okay.
Yes,
start
it's coming.
now.
Okay, do you see my screen now?
Yes, perfect.
Yeah.
Thank you so much. It's a big honor and pleasure for me to be here. And once again, I want to say thank you to my brother Samer El Morsi from Egypt for this kind invitation. And I want to share with you some basic concept about what they call old but gold, that is pterygium approach in the philosophy of Professor Yasergil. And I have no words enough to say thank you to Professor once again for what he directly taught me in the Istanbul time when I was there and during my fellowship time there. And it was great moment of my life and one of the best honor of my life. The title of my lecture for today is for mentoring and honoring Professor Yasergil Leslie is Evolution and Mastery of the Pterygium Approach. And I hope that this lecture can be of some benefit, especially for young people and young surgeons that are, here online, are watching us here. When we take a look to the approach to the central skull base, we see that we have lots of variation, and this is just this is just just some of them. But especially when we talk about the frontotemporal, frontolateral approach, we talk about pterygium approach and this variation. Some of these variation are addictive variation, some of that variation are reductive variation, as the variation that we just saw presented by the colleague. And then we know that among all these approaches, pterygium approach should be considered the must in neurosurgery. And also, when we take a look to the modular concept of skull-based surgery, that is an article that I recently published. And, I stressed the concept according to which pterygium approach is the approach of choice for most of the anterior and middle skull-based lesion, but also, we have to know the history of the skull-based approach, especially for pterygium approach. When we take a look back to the evolution of the frontotemporal approach, maybe the first guy that described this kind of approach was Sir Victor Osley in 1889. And he described for the first time a straight subfrontal approach for giant pituitary tumor. But after that was Cushing to popularize the subtemporal approach that was a lateral approach to the same region here. And then it was the age of Krause in the early 19th with the first description of the extradural oblique subfrontal approach, that it was among the precursor of the pterygium approach. And then Ewert that described on, craniotomy, the first description of frontolateral craniotomy for paracellular and cellular lesion here. And then was the age of the so-called hypophyseal approach with Dandy's flap. As we see here, this is the original drawing of Professor Dandy at that time. And but he abandoned very early this approach because they had no use of magnification of microscope. So the retraction was too much and they caused some damages to the optic apparatus. That's the reason why after that, this approach was a little bit refined. It was focused especially of the lateral sphenoid wing, but MB, and maybe this name is a little bit underrated in the neurosurgical literature, but MB was one of the most important precursor of what we call today pterygium approach. But the true revolution was the microneurosurgical era with Professor Yasergil here that described for the first time the so-called cisternal approach. Cisternal approach is a philosophy, is a concept, it's not just an approach. And after that, he perfectly in 1969 described the extradural pterygium approach with the use of the microscope, just focusing on sphenoid wing. And this is a common modern neurosurgical practice. We used to drill this, lateral part of the sphenoid wing. And apart from some variation that we have already talked about in terms of addictive and reductive variation, the pterygium approach, it's the same. Almost the same in this concept and classical conception starting from 1969. And this aspect highlights once again the genius of Professor Yasergil and what he gave us in terms of innovation in neurosurgery, especially by means of the introduction of the microneurosurgical technique. These are the key steps of the pterygium approach. Everybody knows this basic step, but this is just for young neurosurgeons. As I told you, I want to highlight the fact that the pterygium approach is beautiful and it allows for a subfrontal, transsylvian and pretemporal exposure and corridors to the target. And also this extradural target corresponds to some intradural target and a very, very long list of intradural corridors that we can use. And maybe craniopharyngioma is the best lesion that described when we utilize all of this corridor together. And also, don't forget, never, despite today, you know, this is an evolution of the endoscopic transnasal transsphenoidal approach. That pterygium approach and all frontotemporal approaches are sometimes needed for some para, supra, or retrocellular area lesion. As we see here, we can use pterional and CLC approach in a clival division to approach even the upper fourth of the clivus here. And this is a case of basilar tip aneurysm that was treated with pterional approach. So it means the pterional approach is good for anterior cranial fossa, middle cranial fossa, and also part of the posterior fossa in terms of basilar quadrifurcation. We don't have to forget the basic stuff and the basic aspect of the positioning of pterional approach, and we have to allow, you know, venous outflow from the cranial district. And sometimes I see some videos that, you know, these videos are not so perfect because, you know, sometimes I like to stress some concept about the safe zone, about the skull clamp placement. And Professor Yasergil beautifully described in this book in very early 17 where to put the pins of the skull clamp and how to put it according to the so-called equatorial line. That it is not a must, it is not constant, but they change time by time according to the lesion that we have to treat. And these are the three basic steps to align the target and to optimize our exposure of subfrontal corridors, especially the subfrontal and transsylvian corridors. I don't want to take too much time. Everybody knows, you know, how to put the head and how in terms of rotation, extension according to the target, but the details sometimes makes the difference. In terms of skin incision, we can tailor the pterygium approach according to the lesion that we have to treat. For example, I used to perform, you know, more posterior skin incision for pterygium approach when I have to you know, operate insular glioma, because I like to do this kind of glioma with transsylvian approach, like Professor Yasergil taught to all of us. And this is a concept of cosmetic outcome that is very, very important. It's a little bit underrated also in the literature. Cosmetic outcome is very, very, very important. We have to stay behind the line of, you know, the airline here. And also complication avoidance is another important topic for this kind of approach. And here, don't forget that we have to do every effort to spare the superior temporal artery and auriculotemporal nerve to avoid tedious complication here. And these are the main steps. And also, don't forget that in the face, we have what they call SMAS, superficial muscular aponeurotic layer, and we have to do our best to preserve as much as possible this kind of anatomy and delicate structure. Professor Yasergil described for the first time the so-called interfascial dissection, but maybe the one of the aspects that you know, saw an evolution in terms of you know, technical aspect of the pterygium approach is the preparation of the fascia here and the layering of the fascia. And today, most of the surgeons like me prefer to use submuscular approach because, you know, the likelihood of the damage to the frontal branch of the facial nerve is a little bit lesser, as described already in the literature. But to do this, we have to know very well, and we have to know very well the anatomy of the soft tissue here and outlayering the soft tissue. That's the reason why my advice to the young people is to go to the lab and training themselves to do this. And these are the main steps of the submuscular approach. And then don't forget the so-called Oikawa technique, that is a submuscular approach, that is submuscular technique that allow us to do what? To perfectly recognize, you know, in a retrograde fashion, dissection of the muscle or the suture, because you don't need navigation to do beautiful pterygium approach. You just need to perfectly skeletonize, you know, the suture, and the suture has the best landmark for this kind of approach. As I told you, Oikawa technique and perfect and compulsive superior dissection allow us to decrease the likelihood of the complication. This is one of the most terrible complications for me, that is the temporalis muscle atrophy, and doing your job through compulsive submuscular approach is the way to avoid this, you know, serious complication that is functional but also cosmetic complication. As I told you, I like to always navigate the suture here to recognize where is the lateral aspect of the sphenoid wing and where is the frontal, parietal, and temporal bone. And we can do his, and these are just drawings, but you know, And one of the main aspects to enlarge your working corridor and to increase the so-called surgical freedom and the angular exposure to the target in pterygium approach is the key aspect is the wide drilling of the sphenoid wing. I like to do it even in those cases where, you know, I have to open the sylvian fissure from distal to proximal direction because I want to early recognize the subarachnoid system, the ICA, the optic nerve and everything, because it makes me very confident with this kind of anatomy. When we talk about approach, pterygium approach, Professor Yasergil one time told me, everybody talk about pterygium approach, but very few of them talk about pterygium transsylvian approach, because transsylvian approach is one of the, you know, most important corridor that we use maybe more than 90% of our daily practice in our ORs. And to do this, we have to know all the other corridors related to pterygium approach that are not only transsylvian, but also subfrontal and pretemporal and so-called half and half corridor. These are some, you know, picture and shots during intraoperative just to show how versatile is this approach. And don't forget also the reconstruction here, because the reconstruction is another beautiful step to decrease the likelihood of complication. This is, for example, even in the extremely difficult, challenging case in terms of reconstruction, like this is sphenoorbital meningioma, we should do everything to reconstruct the orbit. And to achieve this outcome, we have to do very critical to reappraise our functional and cosmetic outcome, like in these cases that are part of a series that I recently published. Pterygium approach, sometimes I listen to some people telling that pterygium approach is not a skull-based approach. For me, it's totally wrong. Pterygium approach is the king of all the skull-based approaches. That's the reason why pterygium approach is the starting point for all the variation and the extension in terms of additive variation and reductive variation of the pterygium approach, as we see here. And this is just an overview, and I don't want to take too much time. I already talked about this. This is just to let you know, this is just to describe this kind of variation. I just want to show you some cases that are, you know, to describe how many cases we can use pterygium approach and the fact that it is useful in more than 90% of our daily clinical cases and practice. This is an insular glioma. For example, pterygium transsylvian approach is the route of choice for me in terms of the exposure of the opercular-insular compartment for all this kind of lesion. And this is, I don't have too much time to show you the video, but this is the pre-op and post-op. And in this case, I always like to perform DTI to critically appraise how invasive my surgery was on this kind of lesion. And for sure, we don't have to talk too much about MCA aneurysm. MCA aneurysm today is a surgical aneurysm, not endovascular aneurysm. I want to stress this concept. And to perform this kind of surgery in MCA aneurysm, we have to know very well the basic principle of skull-based approaches, and especially for pterygium transsylvian approach, because this is the gateway to this kind of aneurysm. And also, this is another route that Professor Yasergil described, and this is another contribution of Professor Yasergil to, you know, microneurosurgery, that is transinferior limiting sulcus pterygium transsylvian approach to mediobasal temporal region. And for mediobasal temporal region, like here, especially when we have to deal with the parahippocampal gyrus, most anterior part, the oncus, and also, you know, all the piriform cortex, I prefer to perform this kind of approach. And this is a case of huge tumor, you know, involving the piriform cortex. This is you know, the route that Professor Yasergil described as the so-called, you know, amygdalohypocampectomy, transsylvian amygdalohypocampectomy. And this is the route, and this is the pre-op and post-op. I'm sorry, I'm really sorry, because I don't have time to show you the cases, but this is the pre-op and post-op. I just opened the inferior limiting sulcus of the insula to take it out, this tumor, and the patient, you know, was without neurological deficits after surgery. This is another case that I recently did in my current hospital. I just changed recently my hospital and my affiliation. This is very old guy with this the net, and this the net, you know, the guy was neurologically intact apart from seizure that you know was present in the clinical history, and I did this case through the same perfect way, transsylvian, transinferior limiting sulcus of the insult with pteryginal transsylvian approach, and we have pre-op and post-op here. And also this is the DVI showing that if you are respectful of the anatomy, you can have no ischemic complication, this kind of approach. Pteryginal approach is a beautiful approach also for, paraclinoid aneurysm like this, and this is a case that where you can increase the exposure related to the pteryginal approach, and you can add some variation, like in this case, anterior extradural cranioidectomy. I like to perform extradural anterior cranioidectomy in most of the cases, and when you expose perfectly the target, even if you don't open, the distal dural ring, you can have the space to put the clip and to totally spare the ophthalmic artery, like in this case. This was a case, a surgical case, because not incidental, my ruptured aneurysm with a huge intracerebral hematoma here. And these are the main steps. You see how beautiful is the exposure related to huge pteryginal transsylvian approach. And this is the decompression of the optic nerve after surgery. And we can use this kind of approach in every kind of aneurysm of the anterior cycle and most of the posterior cycle. And this is, another aneurysm, nothing special here apart from the exposure, as you see here. And also for every kind of aneurysm like this, anterior choroidal, you need to beautifully expose and open the sylvian fissure to perfectly recognize this kind of anatomy, especially because the key of this surgery is to sparing the perforator coming from the back wall of the ICA. And also, I like to use, because, I don't like the differentiation between skull-based surgeon, brain surgeon. We are just neurosurgeon, so you can use the technique of drilling, the clinoid, the orbital roof, and whatever you want in your daily clinical practice, like in these cases, intraaxial, extraaxial, or also anterior communicating aneurysm. This is another case where we can add, subfrontal corridor. We can decide to remove the supraorbital band, but every kind of corridor is just related to the pteryginal approach. It is the father of skull-based approaches, even in this case of proximal aneurysm, and also the orbital lesion. This is an article that I recently published. I was very I was very happy to stress the fact that the pteryginal approach is the approach that allows to treat us and to expose 270 degrees of the optic of the area around the optic nerve. Mechal-scale trigeminal schwannoma makes no difference, and we can use pteryginal approach in Jefferson type A, C, and D, and also giant pituitary adenoma. I just finished here. This is another case, also basilar tip aneurysm, but I told you I don't have too much time. Just to let you know that recently I revised our personal institutional series. Pteryginal approach was the most used one, so I'm highlighting the obvious stuff, but it's just to emphasize that pteryginal approach is beautiful for everything. And thank you very much. And I want to conclude with a sentence from Professor, Spetzler, about the fact that in skull-based, and especially in skull-based surgery, exposure is everything. Thank you so much for your attention. Can you hear me?
Yes, thank you, Professor.
Thank you. Thank you.
Yeah, yes, I can hear you. Any question? Excellent talk.
Thank you.
Do you have any questions for Professor Sabino Luisi? It was wonderful hearing him talking about these approaches. Okay.
Thank you.
Thank you
so much.
So our next speaker is Professor Paolo Ferroli from our IRCC Carlo Besta. His topic is the revival of bypass surgery in the endovascular era, a tribute to the pioneers. Over to Professor Paolo Ferroli.
Hello, everybody. I'm trying to share the screen. Can you see the presentation?
Yes, but not in presenter mode.
Okay now?
Yeah, perfect.
So hello to everybody. I must thank the organizing committee for allowing me to be part of this wonderful webinar in which we are trying to honor Gazi Yasergil, who was the father of MCA, SCA surgery. So we were so lucky to put together in the last 20 years a series of more than 180 bypass, and the indication were complex aneurysm, motor disease, cerebrovascular insufficiency, and vascular compromise in oncological surgery. So we started this experience from zero because, as all of you know, in the 80s, STA, MCA surgery decreased a lot and remained only in some centers. And we were able to put together this nice experience with a low mortality and morbidity rate. So maybe we were so lucky because I was born in the year then where Professor Yasergil introduced STA MCA surgery. And at the beginning, it was called a kind of low flow surgery, low flow bypass. But we know that with this kind of surgery, you can bring a flow as up to 150 cc. So it's really a nice surgery. And why there is a revival of this surgery? Because endovascular guys are asking us to treat such cases, like the case I am presenting now. That is a 43 years old man with acute left hemiparesis. He had a giant rupture, partially thrombosed aneurysm with subarachnoid hemorrhage. There was a worsening paresis with a penumbra area. Sorry for this. I'm trying to get back to the slides and not to this kind of screen. Can you see again the presentation, or there's no way to share?
Fell off, yeah.
Okay.
There we go.
So here is the case, and here is surgery. So the plan was to substitute one branch of the middle cerebral artery that was coming out from the aneurysm. The other branch had a good compensation, a good hemodynamic compensation. So we had to perform just the substitution of one branch. You see here the technique for the STA isolation. You see the STA. Here's the cut flow. That is a good way to measure the flow before surgery. And here is the ultrasound examination of the aneurysm. This is something that we love a lot. You see the way you can see the aneurysm with ultrasound by doing it extradurally. You see the aneurysm, the way the flow comes into the aneurysm after contrast. You see dural opening, sylvian fissure opening, bypass surgery. So we are substituting one of the two branches that is coming out from the aneurysm. We perform the microsurgery in the usual fashion. We perform ICG. You see here how the bypass is patent. Again, ultrasound, and this is very important because we see into the aneurysm that the flow decreased a lot, but the aneurysm was not able to get perfectly thrombosed. So without the complete thrombosis of the aneurysm, we have to go on with complete trapping. So the bulking the aneurysm, looking for the other branch, closing the other branch that was already compensated. And you see here the aneurysm and the thrombus that comes out. And this gives us the route to get to the middle cerebral and to complete the trapping. You see the proximal clip, distal clip, and you see here at the end the last ICG that shows a good flow through the bypass and into the brain. So this is the postoperative view, and you see here how the proximal clip could be placed exactly after the perforator. So the trapping was good with no ischemic complication, and you see here the perfusion after surgery, and the patient went really good. So I told you that our endovascular guys are offering us the opportunity to perform bypass, and this is true even after the flow diversion here. You see that the number of papers dealing with this topic, with bypass after FDA approval of stents, went down, and now it's increasing again. And since 2015, we were able to put together 30 patients with the complex aneurysm that required the bypass surgery for their treatment. And here are some more cases. This is a case that I love a lot because it's a giant aneurysm of the unruptured aneurysm of the ICA. And you see that the choroidal artery is coming out from the aneurysm. So this is very important. You cannot perform a complete trapping. And so we choose to bypass the MCA and to put a clip distal to the aneurysm. And you see here the effect of this kind of surgery with the bypass that is bringing blood to the MCA territory, and the flow inside the aneurysm that really went down, very, very low flow after the bypass and distal trapping without any kind of ischemic lesion. And you see that 6 months after surgery, the aneurysm completely disappeared with this kind of flow diversion, bypass flow diversion. So he has no neurological deficit. He was discharged home on postoperative day 3. The aneurysm progressively shrinked, and at the end, the STA-MCA bypass plus distal clipping was like a kind of ICA flow diversion, and the aneurysm was completely treated by this kind of bypass and distal trapping surgery. Some more cases, MCA, these are very easy because you need only to substitute the 2 branches of the MCA that comes out from the aneurysm, no perforators. So you perform the double barrel bypass, and you see that after double barrel bypass, a complete trapping, the MCA territory is well perfused and there is no trace of the aneurysm. So this is a nice case. This is much more difficult because in this giant MCA aneurysm, perforators are involved. You see here the perforators that comes out from the aneurysm, you see here. So there's no way to completely trap this aneurysm, avoiding ischemia. We chose to perform STA-MCA bypass, double barrel, with the distal occlusion, and after surgery, unfortunately, the patient immediately wake up in good condition with no deficit. Also, intraoperative monitoring was good, but after 15 hours, he developed eplegia in the contralateral side, and this was due to the aneurysm thrombosis that involved perforator, but fortunately, in the follow-up, he had a good recovery. This is one more case with the MCA aneurysm. This is a dysplastic case with the giant aneurysm in a 65-year-old man. You see here the aneurysm, and the plan here was, again, bypass and trapping. we chose to perform a radial artery graft. And you see here surgery, you see the aneurysm, dural opening, the aneurysm that is here, the two branches that are coming out from the aneurysm, temporal and frontal MCA branch. We isolate perfectly the aneurysm and we proceed with the radial artery. Again, ultrasound, that is very important in our idea to see directly, immediately during surgery if the aneurysm is going to thrombose completely or not. Here is the microsuture and the preparation of the facial artery in the neck. The facial artery is used for the anastomosis with the radial artery in the neck. You see here the microsuture in the neck, terminal anastomosis. And then we go on with the microsuture on the middle cerebral artery. You see here during the anastomosis with the radial artery graft. The anastomosis is completed, you see. And then we perform, after the microsuture, we perform ICG that shows a good feeling of the two branches of the NCA. So we go on with distal clipping and ultrasound, ICG, good flow. We close. Why we close? And we are happy just with distal clipping. We are happy with distal clipping because ultrasound, this is ultrasound before the bypass. You see the flow inside the aneurysm, and this is the ultrasound after distal clipping of the aneurysm. And you see that the flow is getting slower and slower and slower and slower until it completely stops. So there is a complete aneurysm thrombosis that can be directly seen with ultrasound with contrast enhancement. So we were happy with distal occlusion. You see here the aneurysm that is completely thrombosed, and postoperative DSA shows the complete thrombosis, aneurysm exclusion, and radial artery bypass that was patent with the aneurysm that could be completely cured. You see here the postoperative angiography, no more aneurysm, and the bypass that is well filling the MCA territory. ACA aneurysm is again a nice indication. You see here a case where we choose to perform a bypass in this kind of aneurysm that had the pericallosal artery that was coming out from the aneurysm dome, and also the callosomarginal artery that was as well coming out from the aneurysm dome. You see here the ultrasound during surgery with the usual contrast injection. You see here in the lateral position, the two pericallosal arteries are isolated, closed temporarily, microsutured with a side-to-side anastomosis with the usual technique before the back wall and then the upper wall. And you see here ICG that really shows a good feeling of the two ACA with a new communicating artery between the two pericallosal arteries. Then we go on with the bypass of the callosomarginal artery. You see here the microsuture again with the same technique. So a new communicating artery also between the, and here you can see the ICG of the two side-to-side microsutures with a good feeling of both pericallosal artery and callosomarginal artery. At this point, the patient underwent angiography, and It could be completely coiled. You see here the aneurysm, the bypass that is well working, so our endovascular guys could fill the aneurysm with clip. And here no more aneurysm on the good circulation on both sides through the new communicating artery. So I love this kind of surgery for giant and complex bypass, and I think that tailored bypass surgery remains a valid option for complex aneurysm in order to provide flow preservation. When feasible, it can be associated with endovascular technique to occlude the aneurysm. Both ICA and internal and external bypass show the high rate of patency, also at long-term follow-up, and multimodal management of complex intracranial aneurysm provided a good rate of aneurysm occlusion as high as 95% at the last follow-up. So this is a really nice option for giant and complex aneurysm, but this is not the only reason to keep on doing bypass. You see that bypass can be very good to repair your own mistakes. We are here damaging, not purposely, as you can imagine, the pica in the posterior fossa. In the semi-sitting position, we are above the 9th cranial nerve, and you see that the pica is unfortunately half cut. So we put temporary clips, we go on with the reconstruction in the semi-sitting position that is really uncomfortable for this kind of microsuture. We perform the microsuture, and at the end of the microsuture repair, we check for flow, and unfortunately, flow is not good. You see here ICG, and unfortunately there's no flow through the microsuture and through the reconstructed pica. So we decide to try to reopen the pica, but there's no way, and at the end we are obliged to cut out the portion of pica that was damaged. You see here, we cut the pica completely, and we go on with end-to-end pica anastomosis in the posterior fossa in the semi-sitting position with the classical Tossan approach. You see that with a lot of patients, we are able to reconstruct the pica. We put muscle on the microsuture, and then in the end, the pica is taken after the end-to-end reconstruction. Other indication for bypass surgery that explain the revival of bypass surgery in these last years are Memoriam angiopathy. This is a shared indication with guidelines that encourage us to perform this kind of surgery. This is the way we treat moya. This is the dural opening. We perform also a dural synangiosis, so the dura is opened by saving the meningeal artery. Then we open the arachnoid. We get CSF for research. You see sharp dissection of the arachnoid, CSF collection for research, and then we go on with the same technique. We isolate the targeted branch on the surface. We make ICG before the microanastomosis, and you see here the circulation, the typical microcirculation pattern of moya disease with the pial circulation very rich. Here is the STA preparation as usual, fish mouthing, and the usual technique and temporary clipping for the microanastomosis of the STA on the small superficial MCA branch that was chosen for the anastomoses. You see at the end of the microanastomosis, we remove the clips, we control bleeding, we put a little bit of muscle on the microsuture, and then with just a little bit of compression in the cottonoid and muscle, bleeding stops. And after the bleeding stops, we can perform ICG, good revascularization to the bypass, you see here. And so we go on with the procedure in order to perform a dural anastomosis, synangiosis, and a myosynangiosis. So you see here the dural flaps that are put with the external surface that is contacting the surface of the brain to establish a circulation from the dura to the brain, and you see here the muscle and the periosteum that are used to create the myosynangiosis. So this is the way we treat moya cases in kids with diet and undiet revascularization. More controversial is the atherosclerotic stenochroic disease. We perform bypassing these cases with the crescendo TIAs, with stage 1 hemodynamic insufficiency with still phenomenon, and with stage 2 hemodynamic insufficiency with increased O2 extraction. This is a case, 41-year-old female with current motor TIAs with left hemiparesis, admitted in stroke unit in another hospital, performed DSA, right ICA subocclusion with reduced flow, worsening after 3 days with the right internal capsule ischemia and centralized for care. You see here watershed ischemic lesion, the hyperperfused area that is also visible with CT scan. You see here that is a difference between the perfusion of the 2 hemispheres also with CT scan. We perform a right STA and CA bypass, and here is the good reperfusion obtained through the bypass. You see here the bypass through you see the superficial temporal artery that is entering and going to the brain with a good brain reperfusion. You see that now there is a good symmetry in the time of arrival of contrast. You see here the MR that doesn't show new ischemic lesion, but lesions were already present. So here the almost complete recovery of motor weakness. Postoperative CTA showed a better visualization of intracranial vessel, patency of bypass, MR, no new ischemia, and the NOVA MR showed a flow of more than 100 milliliter per minute, and he could be transferred to neurorehabilitation with good result. So many reasons to go on performing bypass surgery that Professor Yasergil introduced, but what's next? Maybe in the future a new indication is gonna come out, and the group of Zurich is investigating this new indication, that is bypass as a salvage emergency procedure when endovascular treatment of acute stroke fails. So when our colleagues are not able to remove the embolus, to perform an urgent emergency bypass can be an option. There is the issue of dual antiplatelet therapy, because most of these patients are under dual antiplatelet therapy. But we performed 4 cases of STA-MCA bypass despite dual antiplatelet therapy, and fortunately this was possible without any hemorrhagic complication after surgery, despite dual antiplatelet therapy is considered a contraindication to intracranial surgery. So I think that Yasergil taught us micronostomotic brain surgery, and keeping on teaching this kind of surgery to young generation must be our commitment to honor this great maestro. And this is what I'm doing every day. These are my residents in my office. That is a kit with 2 microscopes. So during our everyday life, we spend time by doing the microanastomosis in my office. So I hope that they are gonna keep on doing bypass after me, and this makes me happy, and I think that this can honor the memory of Professor Yasergil. So thank you a lot for the attention.
Thank you, Professor Feroli, for captivating and insightful talk. Any question for Professor Feroli?
Que se voy yo ahorita no me han anunciado.
Okay. Okay, thank you, Professor Feroli. Our next speaker is Professor Jose Valero from USC. So please, Professor Jose, the floor is yours.
You fell off, Jose.
Thank you so much for allowing me to be in this group, and I appreciate the opportunity to give my lecture. And I was not a direct fellow from Dr. Yasergil, but I have been trying to follow his philosophy and working in the Arkansas Neurosurgery Institute and be close with one of his group, which is his group, and one of his partners is also a really good friend of mine, and one of my co-workers, Dr. Arturo Ayala, is also an influence in my participation. And I want to say thank you for allowing me to be here. So I'm gonna talk about gliomas and insular tumor resection, and I think it's part of the philosophy of the legacy of Yasergil when we talk about sylvian fissure. And we need to understand that there is different ways to try to apply these concepts. So why, when, how we treat this patient with insular tumor is important, because time ago, people who were having low-grade gliomas, they were considered to follow those cases because there's challenge to do surgery and not necessarily apply the risk. But now there is a clear situation that we need to do these cases, and I'm going to show again specifically why. So even there is a debate about if you need to do surgery in low-grade gliomas or not. It is clear that as the time has been running, there is more surgical resection for gliomas, and actually with the new classification of IDH, there is a clear concept that it is a molecular glioblastoma when the low-grade glioma is IDH, a wild-type IDH. There's a different clinical criteria that when they start in the time of the Italy group. They show that is some tumors can be considered less risk to be malignant or not. And from that, there was a classification about the patient was less than 40 years old, less than 6 centimeters. A tumor was crossing the midline or not, if it was an oligodendroglioma or not. And based on this and the maximal resection of the lesion, you can consider if the patient was classified to be high risk to become malignant or low risk to become malignant. And if they were high risk to become malignant, so they went to radiation and chemotherapy, and they were low risk to be malignant, observation. So now it's more clear with an advance of technology, we are more capable to do surgery, and with anatomy and the concepts of the philosophy of Yasergil, anatomy will be the best tool that we do navigate our surgeries. Certain concepts that are important to mention is the nodal contrast that is shown in the oligodendroglioma are related to patients with high risk to become malignant, and there is a direct relationship with IDH wild type and patient with oligodendroglioma who has nodal contrast. In this classification of UCSF, they also show something new that was that the presence or tumors in the eloquent area. That was initially a concept to try to prevent to do surgery. They proved that when the tumor was close to the eloquent area, there's also a higher risk the patient to have a malignant lesion and less risk of survival. With all this, we go with different concepts that we have been mentioned about the resection of tumors, the importance of the first 3 months also for the patients to recover, the 1 centimeter rule when we are doing a neurostimulation, the indications of seizures to do tumor resection. And this is an example when you have a tumor close to the motor cortex that you can do navigation, see the track and an arachnoid path that you can dissect it and do a complete resection of the lesion. The importance of use the phase reversal and the moment that you do the surgical resection to try to align that with your central sulcus and be able to do monitoring using bipolar stimulation and then monopolar stimulation to try to identify that track and be able to do a complete resection of the lesion. With the IDH mutant, it's important to understand that now with the presence of IDH mutant in patients with low-grade gliomas, you can consider this a molecular GBM. And that's why the maximal resection of the lesion is so important. So this is the place, or this is the legacy that Yasergil left, yeah. The approach of the sylvian fissure. Nothing more important than this legacy to be able to do a resection of a insular tumor. We can observe how the veins in the sylvian fissure can be different, and we have been having excellent and multiple neurosurgeons here explain their approach to do it and how to dissect the sylvian fissure. But one of the clear issues is our residents doesn't have that opportunity when they get out from neurosurgery. It's really rare that we give to a resident the opportunity to open the sylvian fissure to resect an insular tumor. So I think the same way that we learn in our fellowships and in our training, it's important for them to practice in the lab, be able to dissect these difficult sylvian fissures sometimes, and be able to preserve the space. Here we have a patient with a right insular tumor that we're trying to dissect and make the difference of the space. Let's see if I can. Here we have the frontal lobe, temporal lobe, identify the sylvian fissure. You can start to see in this particular area the tumor of the insular area, how we can dissect it. We can see in white what is the tumor, how we are making those windows to try to work inside of the MCA and be able to resect through. But for question of time, I'm gonna start advancing because I have another video that I want to show you. But we can see tumor here, and we're gonna open more the cistern to try to open and start to dissect the tumor. So dissection is the most important part. Navigation, neuroanatomy is the navigation that we need to use, and we need to understand that we need to dissect from the frontal lobe, preserve the venous drainage of the temporal lobe, try to identify all the insular area, and then identify all the vessels that are around it, and understand that we need to work like a candelabrum inside of the MCA. to try to remove the insula. One of the best exercise that I find out to remove this tumor of the insula is working MCA aneurysm. When you are working and dissecting of the MCA aneurysm and you are able to clip this, as a neurosurgical oncologist, you have become more familiar to the area, and that make you easier to work. So we need to understand that in the anatomy, we have the medial part, we have the lenticular strata branches, and in the posterior part, there's a long branch that go directly to the cortical spinal tract that need to be respected in the moment they're resected. So going from lateral to medial, so we're gonna use the MCA as a candelabrum, and we're gonna resect these vasos of the MCA that go to the insular area to resect it and try to identify this border to prevent to do an infarct and resect the lenticular strata artery. And this is the difference when you have an oligodendroglioma that you can resect it because you have really clear border than when you have a astrocytoma that is more diffuse. In the transsylvian approach, we're gonna try to dissect it in the first 5 centimeters and open that sylvian approach, and try to follow the same anatomy tips and tricks that I mentioned to try to prevent to produce an infarct in the patient. Here, we are trying to dissect it, the sylvian fissure in the first anterior part, and try to dissecate all the MCA until we'll find the frontal insular sulcus to try to dissect it. We see here how the MCA start to become separated, and then we're gonna go all direct to the anterior part with there's the bifurcation of M2. Once we complete it to dissect it, we're gonna identify more or less between 5 to 6 centimeters of dissection that allow you to work inside of the MCA and try to resect the tumor. We coagulate those vasos that I mentioned and trying to resect as possible the tumor in the MCA, and try to preserve anteriorly the lenticular strata arteries, and then to proceed to do the resection of the tumor. The question of time, I'm going to advance. And this is kind of resection that you do after surgery. This is another example of patient where I did an incomplete resection of the insular tumor, but this patient in characteristic was an IDH mutant. It was not a wild type. And this was considered in that moment that I resected as a low-grade glioma, and both with hemangiocytic image, what was IDH mutant. With chemotherapy and radiation therapy, this patient was able to tolerate, and you can see the response 1 year after surgical treatment. So in a transcortical approach, Mischberger also showed for a long time that in counting from in the clockwise, in the zone number 2 is the area where there is more risk to have a neurological damage. And here we recommend to do a transcortical approach to do resection to that area. And this is when you have a posterior insular tumor, and in this area in zone 2 is what is considered to be more risky to cause complication. Other thing that is important, this is an example of how you do the resection. Other thing that is important is that the lenticular striatus can be displaced, but can be infiltrated tumor. And that's why it's really important to see in an angiogram when you have the lenticular striatus displaced. But when they are infiltrated, you can even see here what is a blotch. In this particular case, you cannot do a complete resection of the lesion, and it's important to understand. So working in the cadaver is almost going to be important to try to master this area. This is a surgery that need to be mastered to be good to try to build resection. We have here an example of the long area for the MCA that go to the cortical spinal tract. We had the superior trunk, the inferior trunk. And this is an example of a patient with a tumor that we were able to put the tracks. We can see how the tracks are displayed. This also was mentioned by Yasergil. The tracks normally are displayed by the tumor. And here we have a patient that we're trying to identify that lenticular strata area, and we proceed to use navigation in this particular case to identify if those arteries are displaced or are infiltrated, and we can see it here in this area. So that gives us an example to do resection on this area and use the tumor as a candelabrum. So, and this is the patient before surgery with this plan, and this is the resection after surgery. Anterior tumor that was able to be open and dissected to the candelabrum using navigation on all the anatomy areas. There is no better in navigation than neuroanatomy, but also technology helps us to try to be more accurate with our surgeries. So in conclusion, there is no navigation without navigator, and this is the most important legacy that Yasergil gave us to us. Thank you so much. If there's any question, I'm more than happy to
Thank you,
answer.
Professor Valerio. Thank you, Professor Valerio. Excellent talk. Very detailed in a difficult area of insula. Any question, comment for Dr. Valerio? Any question for Professor Valerio?
Okay, Dr. Sable's next. Okay,
Okay. Sure.
Okay.
So our next speaker is Professor Michael Sabel from Germany, and his topic is regarding Professor Yasergil.
Thank you very much. You can hear me, I suppose, and you can see my slides. Is that
Okay,
right?
sure.
Thank you very much for inviting me, Same and John. This is amazing. You must have a lot of stamina to stay through this. This is a marathon, yeah? Well, amazing. So with my talk, I would like to honor Gazi Yasergil in his role in modern neuro-oncological neurosurgery, and it's fitting well to the talk that we just have heard, because I'm basically complementary to that talk. And I never had the fortune to meet Yasergil in person, but he stayed with me since my young residency with his books, and they're always in the center of my library, framed by Apuzos and humans, but they are the only books that have been read and marked, as you can see here. And I rediscovered him when I became a senior neuro-oncological neurosurgeon, and this is amazing how visionary this person was. So in my talk, I would like to point that out and show you by first going through the definition of modern neuro-oncological neurosurgery and giving you a short history of neuro-oncological neurosurgery as well, to understand how Yasergil laid the foundations for this subdiscipline in neurosurgery. He was a true visionary. Now, a very short definition of modern neuro-oncological neurosurgery would be that glioma surgery balances very aggressive resection against preservation of functionality using real-time mapping. In other words, it's aggressive resection, preservation of functionality, and uses heavily and relies heavily on brain mapping. And what we are doing now in state-of-the-art neuro-oncology is that we tackle and really address the resection of the infiltration zone, which is the functional part of the tumor. That's our target now. We go supramarginal, as well as for the high grades as for the low grade gliomas. This is, of course, only possible, and I will point that out, if we make sure that the functionality is preserved and that we only induce deficits that are tolerable for the patient. And the evolution of this coined aggressive resection is, so we start with the resection of the lesion. Work by Walter Stummer, showing the lesion, taking out the flowing part, the glowing part of the glioblastoma. That's a typical lesionectomy. Then we discovered that the patient would also benefit from resection into the infiltration zone. And now we are going even beyond that. You heard the talk by Atul, who demonstrated that you can go beyond the infiltration zone in the area where you assume that the migrated glioma cells would induce the deficit in due course. And just to illustrate this is a typical infiltrating brain tumor. This would be a lesionectomy, that would be a supramarginal resection. Then we have the point of subpile resection. And now the next generation of neuro-oncological neurosurgery will intentionally go into the surrounding areas as long as functionality is preserved, because we know that tumor cells are located in these areas. Of course, this works only if we preserve functionality. Two critical danger points. First, we need to avoid functional tissue damage, fiber tracts and cortical presentation of the functions. And that can be done by rigorous mapping, always monopolar, which is restricted to motor functions, or to with bipolar stimulation, which is basically not restricted as long as the patient is compliant. And we know where to stimulate what. So we have a certain knowledge about the functionality of the fiber tracts, and we can apply our functional test according to the localization, which we have learned. In the end, a neuro-oncological neurosurgeon integrates the cortical functional areas and the subcortical podological localizations of functionality in an integrated approach. That's basically that part of neuro-oncological neurosurgery. The other part is, of course, that we need to avoid vascular lesions, ischemic lesions. And that is done in, the only way we can do this, to put it this way, is that we respect the pile, not cross the pile, and use the pile corridors to approach the lesion. Stop here because the end arteries are covered by the pile as a protective layer. In most of the tumors, not in glioblastomas, and in some metastases we don't have that, but in many tumors we can use the pile as border. So that is basically what I think is modern neuro-oncological neurosurgery in 25, in a nutshell. Now we look at the history of this development. It turns out that this discipline was basically created in the mid-2000s, when we had a conversion of critical advancements. We learned about 5-LA fluorescence. We had these landmark studies by Zani and other persons who demonstrated that supramarginal resection is feasible. In 2008, 2006, mapping became the standard. Before that, it was done by Hugues Defoe and Mitch Berger, but now it became more standard. And of course, the WHO classification of the brain tumors changed and identified tumors with a better prognosis, and we had a more differentiated approach in postoperative and adjuvant treatments. Now, where comes Yasergil in? Now we have to see that Gazi Yasergil, and remember, modern state-of-the-art neuro-oncological neurosurgery started around the mid-2000s. He already stated in 1980 that glioma's invasive nature means the battle is not just against the tumor, but against its biological behavior. And then he presented us with these beautiful drawings. I will explain later on that DTI was not existent at that time. And when you look as a neuro-oncological neurosurgeon, seeing lots of gliomas in the course of the disease, and you see this picture, you see the progression of the tumor along the fiber tracts. He introduced this concept for the first time. And in 1994, in his fantastic books, Microsurgery 4A, he stated that infiltrative gliomas demand a balance between radical resection and respect for eloquent brain regions. The greatest challenge is not the removal itself, but knowing the limits of the resection to avoid devastating deficits. And that's basically the summary of what I have just said. That's exactly what elite neuro-oncological neurosurgeons do all the day. We try to get to the border of functionality. We need to understand where is the function, and then we need to stop, because harming the patient is not an option. He will lose all his survival benefits. And Yasergil could not work with mapping because mapping was introduced much later. It would have been integrated in his books, of course, when he had seen. Now, the second part of the damage that we can do with this aggressive resection is, of course, the vascular part. And here, this beautiful picture from his 4B book, and the previous speaker demonstrated this beautifully, is that, and that I think that's the summary of all the talks today, is that he he did not invent the subarachnoid space, but he demonstrated, I think, as one of the first surgeons, that it is a natural surgical corridor and provides a natural dissection plane. We have seen so much skull surgery today, and it's basically based on this enlightenment that we can use this as a natural dissection plane without damaging the surrounding vessels or brain structures. And that was a game changer. These pictures. In '84, he started to show us these things. And for neuro-oncological surgery, it is a game changer insofar as that we can, when we take this message, we can travel to the tumors without inducing already a damage just to reach the tumor in many cases. Dr. Valerio has just pointed out, and you see that the intrahemispheric approaches, the approaches to the ventricles, can be done without harming the patient. And this is a paper that has just been shown by Fred Lang. So I think that this school, Yasergil school, introduced these approaches, this understanding of going to the tumor without damaging, and understanding the vasculature of the tumor as well. And again, the tractography became available in the mid-2000s. Now we have, of course, very distinguished ideas about fiber tracts. But Yasergil had to rely on fiber dissections by the Klinger method. And from that, he designed this fantastic understanding of the anatomy of the brain. Cortical spinal tract. How exactly is it located? In which direction do the fibers turn? What you see here is a very important concept of the U fibers connecting the gyri together. You see as well here this interconnectivity of the gyruses, beautifully demonstrated, which has, of course, a very important consequence when we now think about curing low-grade gliomas by aggressive resection. Recent papers by Hugues Defoe and Harvey Jumper demonstrate that we can induce long-term survival with still professional life for 20 to 25 years. But this is only possible when we understand this anatomy, which has been already demonstrated in '94. Look at this picture. This is fantastic. You see the interconnectivity. And of course, the highway on which glioma cells, which are in the migration mode, travel. And that has consequences. When we see this picture, and we see this MRI of a young patient, we know that we want to do the best possible resection for a young person who wants to have normal life expectancy, provided it's a true low grade. And we know that this is basically the areas where we'll have his recurrence. And the consequence is that we do this kind of resection. Of course, neurocognitive training, awake surgery, all the works, but that is a biological idea that Yasergil already implanted into the Society of Neuro-Oncology or Neurosurgery in our brotherhood 20 to 30 years before. And I think that one of the very important things that we do now in neuro-oncological neurosurgery is decision-making, because we have lots of factors that we need to consider if we counsel a patient. And that is one of the modern ones that I have published and has been well discussed and so on. But what is missing here is what Yasergil pointed out already in '94. Indications for tumor operability by Yasergil, one of the most important things is surgeon's capacity and an adequate hospital. So we rely too much on technology, we rely too much on adjuvant treatment options, but the core concept of a person like Yasergil was, first thing, you need to be a very good, not only an experienced, but also a capable neurosurgeon. And I want to finish with this quote, that gliomas teach us humility. Even with all our tools, we cannot always cure, but we must always care. This is deep human thinking. And that's what came out in 3 days of discussion with ChatGPT to create a picture of Yasergil. It's the best that this machine could do. I'm so sorry that I never met him, but I have taken lots of his teaching into the OR. Thank you, Dr. Yasergil, and thank you for listening.
Thank you, Professor Sabil. It's phenomenal and heart-touching. And, you showed the pictures made by Roth, Mr. Roth, somebody who came in young, joined Professor Yasergil. He had no background of medical, and he used to stand beside Yasergil for hours during AVM and glioma surgeries. And it's showing, reflecting the teaching abilities of Professor Yasergil to a level. Thank you so much.
You're welcome.
Thanks for hanging around, Michael.
Thank you, John.
Hey, thank you
Sorry,
very
I have
much.
to rush. I have to run. My wife will kill me if I don't go. Okay, goodbye.
Great presentation.
Thank you.
Okay, Yata, it's all yours.
Yes, our next speaker is Professor Louis Lopi-Ebor, if I'm pronouncing right. He's a neurointerventional radiologist from Madrid, Spain, with extensive experience in neurointervention and neurovascular. Invite Professor Luis. Gazi. Okay, it seems Professor Louis is not around. Professor Samit, do we have any next speaker? Okay.
Hello. Next will be Marvin.
Marvin, okay, sorry. Yeah. So, Professor Marvin, floor is yours, please.
No, I'm sorry, Marvin was caught in a storm in the Caribbean. So he would
Okay.
internet
Okay.
connection
What
was
about
bad.
what about
Who's next, Sam?
give me a minute. Yeah.
Is Dr. Lanzino next? No?
Yes, please, Professor Lanzino.
Okay.
Professor Lanzino, are you ready?
Are you trying to get a hold of Dr. Lanzino? Are you there, Dr. Lanzino? Perhaps not. Perhaps he stepped away. Okay, Sam, who else is available?
Let me check.
I think. Let's see here. I don't see anybody in the panel. Let's see, amongst the panelists, should Dr. Lanzino is in. Or Dr. Wang, I see a presenter.
Okay, we will wait for Professor Lanzino till he join us and be ready.
We're trying to rustle up the speakers. I'm going to write to Dr. Lanzino. Oh, okay. Let me. Okay, hold on, folks. We're waiting. There could be one more speaker. We'll just wait a few minutes.
Okay, Arturo Ayala, are you ready? Please upgrade Arturo Ayala for panelist.
Yeah, okay. Okay, Arturo, you're listado. He was in, I don't know. There he's okay. Here he's in. Okay, Arturo, él está aquí. He's here. He's coming in. I think Arturo Ayala de Mexico is going to be presented. Arturo, are you there? There he is. Okay. Arturo Ayala, he's a neurosurgeon from Mexico. And I'm glad you showed there, Arturo. It's all yours. Can't hear you. Is your microphone on, Arturo? Your microphone, is it on? I don't believe your microphone's on. Hello, Arturo, your microphone is on. Can you speak? Arturo, it shows that your microphone is on. So can you try to, are you connected okay? I think he's not connected. Do you see, Arturo? Oh, Dr. Lanzino's here. Okay.
Hey, sorry, I had to step
That's
out
okay. How
for a
you
few
been, Dr.
minutes.
Lanzino? How you been, Dr. Lanzino?
Good, good.
Good to see you. It's all yours. Dr. Lanzino,
Okay.
a very friendly guy from the Mayo Clinic, and I'm sure he has some good presentation about Dr. Yasergil. Welcome, Dr. Lanzino.
Thank you. Thank you. I'm opening 1 second. It's of course an honor for me to be able to pay tribute to our mentor, idol, and teacher. Unfortunately, I've not had direct association with Professor Yasergil. When I started in the late 80s in Bologna, my mentors strongly recommended me to try to carve some time and to go and watch him, but by the time I was able to arrange, he had retired and left Zurich. He has, of course, like many of us, profoundly influenced my development through his teaching, his stature, the books. And I thought that it was fitting paying tribute to him and discuss specific type of tentorial dura-levi fistula because they summarize the importance of fine anatomical knowledge. They summarize the advances in knowledge that have occurred since the early 70s when Professor Yasergil made his incredible contributions to microneurosurgery. And it's one of those diseases and one of those problems where technological advances, particularly endovascular techniques, have been critical, but there is still a very important role for microneurosurgery. Among the dura-levi fistulas in general, tentorial ones are relatively uncommon, but are often a cause of hemorrhage or progressive neurological deficits, even though more commonly, especially in the Western world, nowadays, some of these fistulas are discovered in an incidental fashion. Now, Dr. Lawton has classified tentorial dura-levi fistula into marginal, lateral, and medial type, with the medial type basically including the anterior or the so-called galenic and the posterior medial, which are fistulas that involve the mid or posterior third of the sorry, they're telling me that you cannot see my presentation. I apologize for that.
Not yet.
Let's see.
Yeah, click on the share button first. You know
I
that,
need
right?
to.
Are you in a complicated setup with the university?
No, I think I'm one of those two-screen projectors, and can you see now?
Yeah, you're starting. You're starting. Okay, good. Put it on presentation mode. That's good.
Okay.
Perfect.
Can you see now?
Yeah, perfect.
Okay. Sorry about that. So the when we consider the posterior medial type, they, like many dura-levi fistula, they can appear quite complex on the imaging, but once you are able to decodify the fistula, the solution is fairly simple. And for this specific type, the arterialized vein emerges from the dura immediately of one side of the midline. And we will see that that's an important factor to understand and consider on the angiogram. And it involves usually one of the medial posterior bridging veins. So the arterial supply is often from the middle meningeal artery, the posterior branch of the middle meningeal artery, the posterior meningeal artery, but in the occipital artery. But there is often supply from, sorry, Jim. There is often supply from less common arterial feeders, like the particularly there is a feeder from the superior cerebellar artery, the so-called artery of Walsh-Hager and the Walsh-Hager. And as the feeding vessels, they become hypertrophic, you can see that there are also dural branches from the posterior inferior cerebellar artery, which have been not very well characterized in the literature, as normally they are very, very small. The angiographic characteristics are fairly consistent. You can see in the typical form, you can see that everything converges into a arterialized draining vein, which emerges from the undersurface of the tentorium immediately on one side of the midline, and particularly for the surgical approach, to carefully look at the AP view of the angiogram. It's important because you can see in this particular case that the fistula is immediately off the left side of the midline on the angiographic view. Now we'll go through a couple of cases. This is, as I mentioned, it's not uncommon nowadays that some of these fistulas are are discovered incidentally. This is a 61-year-old who had been previously treated with stereotactic radiosurgery for this incidental CP angle meningioma. And what you see over time, this is in 2017, and on the right is 2021. You see that on the right side, there is a progressive development of abnormal vasculature, with, as you can see in this case, with the interval development of varix. At that time, we thought this could have been either a distal pica aneurysm or a AVM with a feeding pedicle aneurysm. But when we did the angiogram, you see the classical pattern with, in this case, posterior meningeal artery supply, and the dural branch of the superior cerebellar artery, each converging into an arterialized draining vein, which from the undersurface of the tentorium fills in a retrograde fashion, affecting the drainage of a significant part of the cerebellar hemisphere. And you can see the interval development of a venous varix. And this is a classical example of why in a dural AV fistula, often the bleeding could be far away from the actual point of fistula, as the bleeding point is usually represented by a venous varix. Very important, as I mentioned before, the AP view, and here you see that same posterior meningeal artery and the superior cerebellar artery branch converging into a vein which is localized on the left side of the midline. This is a surgical view. The patient is in the semi-sitting position. The semi-sitting position in these particular cases is very, very important because often due to cerebellar congestion, there is edema of the cerebellum. So the sitting position helps a lot in order to facilitate collapse of the cerebellum and access to that infratentorial space. And you can see here that immediately off to the left side of the falx cerebelli, there is a large arterialized draining vein. It's important to really skeletonize the vein to be able to make sure that you have indeed identified the actual point of emergence from the dura. And there are several situations here. You see the ICG fluorescing and equivocal early drainage with shunting. And as I said, once you have decodified the fistula, the treatment is pretty straightforward and consists of closure of the draining vein immediately after the dura emergence, either with the clip or with the coagulation and division. And here you can see the pre and on the right, the post CT angiogram with the surgical clip and lack of opacification of the draining vein. This is a different case. Just to in this particular patient, the fistula is on the right. The previous one was on the left. Patient again semi-sitting position, midline incision, and just sliding above the cerebellar surface to identify the arterialized draining vein. You can see here emerging from the undersurface of the tentorium along the falx cerebelli, and again, important to really skeletonize that vein in order to identify the exact point of emergence. And then, as I said, once that is done, the treatment, it's fairly straightforward. This is another case that patient minimally symptomatic, a 61-year-old, suffered a minor head trauma. Shortly thereafter started developing headache and intermittent disorientation. An MRI was done, which again identified abnormal vasculature in the upper portion of the cerebellum along the vermis. And this is the angiogram. This is a selective external carotid artery injection. And you can see that whenever we see a nice middlemeningeal artery feeder going to the fistula, the middlemeningeal artery is the best friend of the interventionalist because it's the straight vessel, it's a dural vessel, does not have any parenchymal supply, and it allows us to be able to navigate a microcatheter all the way close to the point of fistula. Vertebral artery injection, again, you see a posterior meningeal artery that supplies a fistula, which emerge with the draining vein emerging from the undersurface of the tentorium. In this case, you can see here, it's on immediately off the right side of the midline. And again, you can see here the microcatheter, the selective injection. We are very close to the point of fistula. And once we are able to achieve this point, this distal microcatheter position, then treatment with the onyx. And you can see here the onyx cast, which is filling not only the proximal portion of the draining vein, but also that fine network formed by branches of the middlemeningeal artery, posterior meningeal artery, superior cerebellar artery, that eventually leads to complete occlusion of the fistula, even though the treatment, the goal of treatment is interruption of the proximal portion of the draining vein. When you do onyx in such a situation, we have to be careful because in a retrograde fashion through the posterior meningeal artery, you might feel the vertebral artery, or you might feel retrogradely the superior cerebellar artery. So endovascular treatment in these particular cases does have a lot of nuances, and it's not without potential dangerous consequences. And here you see the final super selective middlemeningeal angiogram. You see the dural drainage, normal dural drainage, but no evidence of residual fistula. And this is the final angiogram. And you can see how there is still persistence of that pseudophlebitic pattern because the cerebellar veins were profoundly affected by the presence of the fistula. So in conclusion, posterior medial dural AV fistula, a specific subtype of intracranial dural AV fistula. Although the pattern, especially when it comes to feeding arteries, can be variable, the drainage, it's fairly consistent. And once you understand the specific type of fistula and you localize which side of the midline and which third of the undersurface of the tentorium along the course of the straight sinus is involved, then the treatment is pretty straightforward. And we have gone a long way from the early pioneering effort to the modern treatment of dural AV fistula, which can be carried out in the vast majority of patients with great safety and great result. Thank you.
Okay, Arthur.
Thank you, Professor, for your excellent talk. Forum is open for questions. Okay. So,
Great. Thank you, Dr. Lenzino.
thank you so much.
Thank you.
So our next speaker is Professor Arturo Ayala from Mexico. He's a skull-based neurosurgeon, and he's going to have his presentation. Please. Podium is for Professor Ayala.
Hey, are you okay, Arturo? Is your mic working?
Yeah, Professor.
I don't think your mic is working. Yeah, your mic is not working. You're gonna turn it on. It's at the bottom left of your screen. You gotta turn that little video camera on. Because it looks like you seem to have a okay, you're muted now. I need you to unmute. Still no sound. It could be your volume. You may need to turn your volume of your sound up on your computer. Are you using a laptop or desktop? Because I think your volume is off on your laptop, because I can see your camera connected okay. I'm going to stop you, okay? And I'm going to, okay, come in again. Try to unmute. No, that's not working. Okay, Arturo. You might need to reboot like go off the computer and come back in, okay? Arturo? Leave leave the webcast and turn off your computer completely and return. That might work. Okay, he's taking my advice. He's crazier than I thought. I just wait a second. Give him a good shot. You know, 90% of the problems with the computer are taken care of by rebooting. You know that, Sam? A lot of problems with the computer are cured by rebooting.
Okay.
That's what Arturo's doing now. He's trying to reboot to see if that'll clear up the issues he may have.
So, Professor Same, is there any other speaker so we can?
Okay. I will ask some to hurry and come.
Okay.
In that video we had, we couldn't get going, Sam, we can try that at the end, after everyone has spoken. Okay? Gonna wait for Arturo and just keep our fingers crossed. You know what I'm gonna do? I'm gonna try to run the Japanese presenters video. Yeah, maybe we'll close, but let me see if I can run that video, okay? Because he put it together and he was hurrying home to oh, okay.
Good afternoon.
Okay, I think I got it.
Good afternoon. It is a great honor to speak at this special Zoom meeting held in
Okay, I'm gonna share this. Dr. Hatagawa. Okay, this is Dr. Hatagawa. I'm gonna share him. Okay, and tell me if you can hear it, okay?
Good afternoon. It is a great honor to
Can you hear
speak
it?
at this special Zoom meeting held in memoriam of Professor Gazi Yasergil,
Yes, it's
the
yes.
legendary Turkish neurosurgeon who
Yeah, we can hear.
transformed the way we approach the brain. My name is Hirotaka Hasegawa from Saitama Medical Center, Saitama Medical University, Japan. Today, I would like to share with you our journey from microsurgery to endoscopic microsurgery, transcending traditional limits and redefining surgical standards. Professor Yasergil is widely known as the father of modern microneurosurgery. He introduced the surgical microscope to neurosurgery, pioneered safe access to deep-seated lesions, and established key techniques for aneurysms, AVMs, and epilepsy. Most importantly, he championed microanatomical dissection, a philosophy grounded in precision and a profound respect for anatomy. His legacy continues to guide us today. Professor Yasergil said, surgery is art and science. His approach was never just about technique. It was about anatomy, precision, and the profound responsibility we bear as surgeons. I had the great privilege of meeting him in person in 2016 when he visited Japan to give a lecture at the Keiji Sano Lectureship in Tokyo. I still remember the strength in his voice and the clarity in his message that every movement under magnification should reflect humility, excellence, and a deep anatomical understanding. His spirit lives on each of us and in every microsurgical and endoscopic movement I make. Professor Yasergil described surgery as a conversation with nature, grounded in anatomical respect and precision. Building on that legacy, I now focus on endoscopic transnasal surgery. It offers a direct midline route with minimal bone retraction, a clear anatomical advantage over conventional approaches. However, traditional ETS have its challenges: narrow working space, one-hand limitations, and restricted precision around critical structures. These limitations led us to evolve the technique toward what we call endoscopic microsurgery. So this is the concept of endoscopic microsurgery, combining endoscopic visualization with microsurgical principles. By expanding the corridor and enabling bimanual dissection, we can perform delicate handling of nerves, arteries, and brain structures, just as we would in traditional microsurgery. This approach allows us to tackle intradural skull-base lesions with the same precision and control, but through a minimally invasive route. One of the major complications of endoscopic transnasal surgery is CSF leakage. which can lead to life-threatening meningitis if not properly managed. The incidence varies significantly depending on the grade of intraoperative CSF flow as classified by Professor Esposito. In high-flow cases, the risk may exceed 10 to 30%, making reliable skull-base reconstruction absolutely essential. To prevent CSF leakage, no single layer is insufficient. The first key is a multi-layered reconstruction. We use a combination of materials and techniques, starting with intradural and inlay grafts, which is sutured in a watertight fashion, then only fascia, rigid support, then sphenoid mucosa. You can use a fat if there's a large dead space, otherwise sealant to secure everything, and sinus and nasal packing. Second key is watertight dural closure using a fascial patch and a suturing technique. We use either multiple interrupted stitches or continuous sutures. This technique is not only technically feasible, but also highly effective in preventing CSF leakage, even in high-flow Esposito grade 3 cases. In our recent series of 50 consecutive high-risk cases, we had only one CSF leak, which was due to balloon self-extraction, not reconstruction failure. This highlights the importance of active watertight closure as part of multi-layered repair. For deep skull-base lesions, precise approach planning is critical. This is a large pliable epidermoidal cyst which is encircled by cranial nerves, brainstem, cerebellum, and a temporal lobe and bone. While we would have to get through the cerebellum and the temporal bone and handle the cranial nerves through the retrosigmoid approach, transnasal corridor would give us a direct access to the tumor without being interfered by critical neurovascular structures. What is true, it can be difficult to imagine how it looks during surgery. In such situation, precise 3D simulation play a significant role to preoperatively check the surgical access to this deep skull-base lesion. So this is a 3D simulation created using a grid, which was invented in the University of Tokyo by our colleague. Now let's move on to actual surgical cases. As I showed, this is a large clival epidermoidal cyst in a 29-year-old man. You see, this is a large clival opening, and after cutting through the clival dura, you can directly see the basilar artery, and this is the 6 cranial nerves. On the other side here, and using the 30-degree endoscope, you can remove the tumor up above the through the nerve and tip of the basilar artery. So this is the lateral side cranial nerve, 7th and 8th, 6th nerve, and 5th nerve. And after that, you can do multi-layer reconstruction using the dragon and fascia, which is sutured, this time used using the 4-0 strata fixed spiral continuous suture here. And then you can just cut it out. So this is a nice reconstruction, and some septal bone for rigid buttless and fat and fibrous glue to fill up the space, and covered with nasopharyngeal flap, and finally some sealant is added and nasal packing.
It's a stop also at the same point. Maybe download there's something wrong.
Yeah, I think this is what happened.
Okay. Are you ready?
Okay. We tried once again, didn't work. Okay, Arturo, are you there? Let me check to see if Roberto's here. If Roberto's here, he's gonna give a talk. He's coming in.
Hola.
Roberto, come on in. Now Arturo's here.
¿Me escuchas?
Yeah, okay, we'll go. Yeah, okay,
Next
Roberto.
case is a large craniopharyngioma in a 52 years old woman.
Okay, here we go.
This time,
again.
I selected a transplant tracheal approach
surgery.
with hemihypophysectomy.
Okay. Okay, Roberto. Roberto is a neurosurgeon from Argentina. We worked with him a lot, and I'm sure he had many meetings with Dr. Yasergil. Welcome, Roberto. It's all yours.
How are you?
Good.
John.
Great to see you.
Good, good. Okay, I'm ready.
Yeah, go ahead.
Good evening, everybody.
Okay, Roberto, you're going to present?
Okay, going to share the screen.
Okay.
Can you see and hear me? Yes.
Yeah, you haven't, you're going to open the PowerPoint? We see
John, John, Auto is in
no,
attendees.
Roberto started.
Okay. Just upgrade the Auto to panelist, and he will go after Roberto.
Okay, you're next, Arturo. Okay, Roberto, it's all yours.
Okay.
Yes.
I start
Okay.
my presentation. Good evening, everybody from Buenos Aires, Argentina. It is an honor for me, a great honor for me to take part today of this Professor Yasergil tribute. Thank you very much, Professor Morsi Hassan, for inviting me and all of you for hearing me. I'm going to talk about Professor Yasergil in his last book, Neurosurgery in 4 volumes, that was published in 1994. He said, personally, I'm convinced that this will be the case in the near future in the modern computerized side operating room, where the combined morphological and functional anatomical 3D dynamic models can be examined and checked according to the needs of the given situation with respect to the desires of the surgeon. Here. Why Professor Yasergil said that? Because it is very difficult to distinguish the tumor of the normal brain. It is very difficult to know where is the tumor when we open the head, where the tumor begins or ends, where are the functional areas, and the most important, how much of the tumor we remove and how much we have to remove it even to remove. We know what we have to do respect in the surgery of the glioma. We have to remove it completely, either in low grade or in high grade glioma, preserving the neurological function in our patient. But this is the goal of the treatment, radical surgery in low-grade gliomas and in high-grade gliomas. 2 years after Professor Yasergil published his book, Peter Black in Boston, Brigham and Women's Hospital, was the neurosurgeon who operated the first patient using with the glioma using intraoperative MRI. Argentina was the 5th country in the world where a brain glioma was operated using intraoperative MRI guide. It was our first surgery on July 2000. From this date, near 1,000, very close to 1,000 gliomas we operated in our apartment using low field, small device, intraoperative MRI. I'm going to show you a few cases. For example, in high-grade gliomas, we can't cure these patients, of course, but gross total resection can improve the survival quality and extend the life in many patients, even to 3 or more than 3 years, of course, with complementary treatment, radiotherapy, and chemotherapy. This is the hypothetical approach to a frontal lobe tumor. We can't see the tumor in the most of the cases, but yes, we can see the tumor with MRI. It is a case of 82 years old man with GBM with this high-grade glioma. This is the first intraoperative images in the first check after removing a piece of tumor, but with this important remnant here, with this remnant here, we can see clearly the remnant of tumor using intraoperative MRI. And this is the last control after we remove completely the tumor. It is a gross total resection and no more tumor in different sequences. This is the difference between see during the surgery and operate without a guide of images. And this is the patient 26 months after surgery, fully recovered and without neurological dysfunction. In low-grade gliomas, we think that a good surgery could be the cure in many patients because a lot of patients can be alive more than 10 years after surgery and free of tumor. This is one example in this diffuse low-grade glioma, frontal lobe. This is the aspect of the surgical bed, and this is the little remnant we detected with intraoperative MRI. We had the possibility to remove this piece of tumor, and this is the patient with completely normal life, 18 years after surgery. And we have patients with 25 years after surgery in low-grade glioma, completely free of illness. This is the MRI of this patient, all the pictures, no one picture, all the picture of MRI with no tumor, patient completely normal. In midline tumors, it is important to have the guide of images. This is the tumor. In this case, we are using now fusion of the images and artificial intelligence in the same program. And this is the images that we achieve with a mark at the center of the tumor. And this is the tumor here and the tumor with some marks at the bottom of the cavity after removing the tumor. This is the approach. This is a picture of the approach, transcortical approach. And this is the patient completely normal, a young lady and this is high field MRI with no tumor, the patient completely normal. Other case in the big tumor, low-grade glioma tumor, we can operate in prone position with some marks at the bottom of the cavity. And this is the high field MRI several months after surgery with no tumor. The patient 2 months after surgery. The image is an important, I think, is the best tool to operate glioma. And we will see in the near future that intraoperative MRI systems will be smaller than the actual devices, with low cost, simple, practical, easy to use, fast, neurosurgeon friendly. We need a MRI, new devices that respect the condition of conventional surgery. This is the view of our system. Here we are operating in normal condition, and it is important with a simple rotation movement of the surgical bed. In less than 1 minute, we cover the patient and move the patient, and we are in condition to get MRI images. We published our results using this new device last year in European Society of Medicine. I'm going to show with this case. Here you can see on FLAIR with this remnant here, we can detect clearly this remnant of tumor in the first control. We go on with the surgery. Here we can see a thin layer of tumor remains here, and we go on with surgery. And this is the last control with no tumor here. And the high field MRI several months after surgery with no tumor remnants, the same in T2. And this is the patient completely normal. This is the surgical bed of his brain, her brain, with no tumor. The patient is very, very good outcome. We think this is the way. The things are changing. We are, for example, my good friend Professor Atenenam in Aga Khan University in Pakistan, are using this device. He operated using this device, ultra low Tesla device. It is a portable device, and he operated the first patients in Pakistan. Recently, Professor Mitchell Berger, who is an oncology neurosurgeon very known for all of us, said that the future of glioma surgery will be image-guided navigation with intraoperative MRI. And he said that in the next 3 years, he way to have one device of this small device. And a few days ago, my good friend, Professor Ipecherian, who had this 3 Tesla intraoperative MRI in Nepal, I visited my friend, I was with him operating in this amazing room. But he said a few days ago that now working on this completely nodular and portable intraoperative MRI system with amazing growth from use, and this I am sure will completely disrupt how neurosurgery is done, and maybe many other branches of surgical sciences too, because it could be used in the future by orthopedics or general surgeons. New developments in intraoperative MRI imaging devices are on the way and will be the future that Yasergil predicted in 1994 to check the step-by-step the surgery during the surgery when neurosurgeon need to do it. I imagine perhaps in the near future, we will have intraoperative MRI system that can be used in neurosurgery pathology as we use today the CRs to assist the surgeons in orthopedical and spinal surgery. I think in the future we can see C-arm MRI. It's possible. And it's possible we can use this, apply this in other surgery. For example, we have this ventricular catheter on the floor of the cavity of the sphenoidal prolongation of the lateral ventricle, who was dilated. When we try to reroute the ventricular catheter, the tip of the catheter touch here the brain, and the catheter bent and did not progress in the correct way, in correct direction. We get in less than 4 minutes, we got intraoperative images. We see the correct final direction, the catheter, and the dilation disappear here. You can see the catheter here. And this is the CT scan after the reroute the catheter, and the patient very good. We can check every neurosurgical procedures if to get intraoperative MRI is easy. Here we check this subdural, and you can see in real time if the catheter, the drainage is in good position, if you drainage completely the hematoma. In the future, intraoperative MRI, different devices could be a good help for the neurosurgeon. And we can use it for other application. For example, we use to do the lead in this regrow tumor here, a little piece of tumor. The patient refused to be reoperated, and we decided to do laser ablation of this lesion. We use this device. We're checking the step with intraoperative images, and here you can see 6 months post laser ablation with the resolution of this small piece of tumor. Recently, we practiced it to laser ablation guided by images in a case of hypothalamic hamartoma. We can do this lesion here in the hamartoma with lead. And in the future, perhaps this is not my experience. I think it is in this picture was taken in Japan with different applications of radiotherapy, thermal therapy using control intraoperative, and even this we can put in the future perhaps the screw in surgical spine using MRI in OCR. 25 years experience and very close to 1,000 patients operated with low field intraoperative MRI. This was our first surgical table and our primary coil to use during surgery. From this surgery, this first surgery to nowadays, we pass 25 years, and this is the real day. This is the surgery guided by intraoperative MRI in nowadays. We had a new headrest, we had a new stretcher, and I think different devices could be the next step in intraoperative MRI. And these devices must to be smaller, easy to install, easy to use, and of course, low cost to do that, accessible to all kind of departments or all kind of country in development or not developed. I think to operate a glioma with intraoperative MRI is not longer a luxury. It is an urgent necessary. To finish, I think there are 3 types of people in the world. It's not my words, but something said that there are 3 types of people in the world. Those who make things happen, those who watch things happen, those who wonder what just happened. And I think there are 2, a rare kind of person, like it was Professor Yasergil, who imagines long before what is going to happen. That's why it is my honor to today remember Professor Yasergil, and I want to thank you very much for him, and rest in peace. Thank you very much.
Okay, Arta.
Hello. Thank you.
Hello.
Thank you, Roberto, for this excellent presentation. Hello.
Okay, go ahead, Sam. Go ahead, Sam.
Thank you, Roberto, for this excellent presentation.
Thank you. Thank you.
Okay, Sam, we can't hear you. Okay, thank you, Roberto, for a great presentation, and we'll see you soon. Okay, the next speaker is Arturo Ayala. He's a neurosurgeon from Mexico. We had some problems getting back on, but we think this is going to work.
Yeah. Are you listening?
Yeah,
Okay.
Your sound is the best all night.
Thank you. Well, I can share my presentation now.
Perfect.
Let me see. Excuse me, let me out. Okay. Let's see. Well, like John Bennett said, I'm from Mexico City. I was an ex-fellow in the UMS, and I have the fortunately be with Dr. Al-Mefti and Professor Yasergil on their philosophy about the microsurgery. Now I cooperate in Latin America Valero Foundation here in Miami, and thank you so much to Dr. Jose Valerio too. The title is about arachnoidal ward, the most common arachnoidal corridors, and the Yasergil's philosophy. And Dr. Yasergil said before we need learn anatomy, and the anatomy is a chart how the microsurgery applied in this book, and all these contributors, all these authors are at the common denominator as patient, the specialist. And obviously the arachnoidal space, I don't explain this, but I found a new research about the meningeals and composition of all these membranes in this beautiful article in Neuroscience Nature. And in the end, all the Professor Yasergil said about tuberculosis in the arachnoidal space and about the metabolism and about the vessels. He says sometimes the vessels are not tubes, have a lot of neurophysiology changes inside and around of these vessels. Then this it has been recognized that the subarachnoidal space, and in particular the cisterns, can provide a natural pathway for dissection that preserves all important brain structures and have an important relationship with the cerebrovascular system. Then Professor Yasergil have a classification of this subarachnoid cistern that all we know, supratentorial cistern and infratentorial cistern. And I think one of the most important ways to go to the reach all the structures and from vascular and neural components of the brain are from these beautiful drawings that he showed in his documents, in his books. Then one of the first is the Sylvian fissure, and we can see, I don't late in this because I have two lectures before than me about this. And the most important is the arterial anatomical variability. And this explains that we need study very well all the studies, all the images of each patient. The venous anatomical variability is more complex too, and we can remember the types of the Sylvian fissures that Dr. Yasergil proposed this classification in the brain, and you can see how the Sylvian fissure is wide here in the atrophic fissure, or some a little bit strange here in between temporal and frontal lobe, and the most complex is when the frontal or the temporal lobe is herniated in this side. Then about the structure of the cistern, Professor Yasergil that have this proposition when we have a large cisternal with transparent and fractured intraabdominal characteristics, or small, but sometimes we have a large and thick and tough and very difficult to dissect, and obviously the small and thick and difficult to dissect. This is the drawings that the Professor Yasergil has in his book. And obviously, how can we measure the subarachnoidal cisterns? We can make this cisternography, or maybe we can try to spend time with the analysis in the MRI or in sequence in CT scan too. And obviously, the cadaveric specimens are very useful to try to understand how important is the analysis of the subarachnoidal space. The art of surgery is based upon a number of factors, such as basic knowledge, experience, judgment, and manual dexterity, as well as qualities of courage, decisiveness, patience, and endurance of the surgeon. Surgical skill relies in the integration and combination of a variety of abilities, methods, and mental attitudes in order to promote proficiency and high standard of surgical performance. Obviously, these words are from the master, the Professor Yasergil. We can see how can dissect the Sylvian fissure and in the direction of from external to internal, and obviously sometimes we can make in diverse sense. The art to open cistern sometimes is very easy, but sometimes it's not. Then we can try to analyze all the surgical corridors to enter inside of the brain. This is my first video. We try to describe how we can open a wide Sylvian fissure with a lot of CSF inside, and we can see the movements to try to understand the anatomy and try to dissect the arachnoidal layer in the case of the Peckham aneurysms, and we try to describe how we can make the movements in this case. Then you can see we have a sharp dissection. We don't use any kind of retractors here, and we try to describe how the surfaces of the arachnoidal layers are to dissect. Yeah. Then we can try to open all the layers, and every step is important to dissect, and every step that Dr. Yasergil making in his book, and that beautiful describing these illustrations, we try to open all the structures to release the CSF. And it's important that this is the fundamental of the successful aneurysm clip. Then in the video, you can see the aneurysms here, and we can see the carotid and optic nerve, and we are trying to discover the PICOM infundibulum, and we see the aneurysms here, and we try to dissect the anterior choroidal artery. Then we can see how delicate movements are described here. I will forward a little bit because of the time. And you can see this, the final part of the sylvian cistern here. And we try to open very, very smooth with the delicate movements. And you can see how can I dissect. This is the final step. And after this, we can open very widely the sylvian fissure. This is the how can open it, and instantly we can open the book, and we can see everything the structures are in there. Okay, with this step we can analyze very good all the carotid and all the components here, and we are ready to put the clip. We can see the anterior choroidal here. And we put the clip in the neck of the aneurysms. The most of the time, we try to make a good edition of each videos, and we skipped many details about it. But I think you have all these videos in YouTube, and without edition for all the young neurosurgeons and residents to try to see in the real time what need to do. Okay, we have all the steps that Professor Yasergil described here, and this is the result. And obviously the clip was very well clipped, and the clip is in the position without any kind of stroke. Okay, the microsurgery need instruments, especially designed for the micro dissection. And the dissection of this, we need micro instruments like spatulas or tube draw, and a good suction tube with protection in the point, and obviously wide kind of forceps to make the dissection sure. Then what conditions complicate that dissection? Cerebral edema, hydrocephalus, infarction or stroke, hematomas, very firm thumb, heart transplants, or the anatomy inside. Now we can see this hemorrhage here, but the brain is very lax, and you can see the clip here. But sometimes it's not easy. Sometimes we have this like a boxing glove here, and you can see how difficult it is. This is another case for another PICOM aneurysm here in a patient with a hemorrhage. And obviously the terminal approach is one of the most important surgical approaches to reach the most of the cases in aneurysms. And you can see this is a very tight sylvian fissure. We have a temporal lobe and the frontal lobe very narrow. And then we try to open this cistern. The cistern is easy to find, and you can see the MCA inside. And we try to open it. And it's important, the movements, this video is a little bit fast because of the time, we can see the optic nerve. We can open the pericarotid cistern. We can go to open the lamina terminalis there. We can see the bifurcation of the carotid, and we can see the M1 segment. And now we are in the structure of the carotid, internal carotid, and we can find the neck in this position. Now we can see the anterior choroidal vessels here, and we are ready to clip the aneurysms. We put it very gentle. Now we see very well the posterior cerebral, the posterior communicator, and now only for academic purpose, we try to make a endoscopic view to try to understand how we can see sometimes the size of the aneurysms and the size of the clip position. Yeah, we can see now, and the end of this video is this one. We can see this kind of view. It's nice to try to construct in the mind of the surgeon all of these images. This is the final CT, and this is one of the last aneurysms, ACOM aneurysms here, and you can see now we try to follow the sylvian dissection, the ragnoidal dissection that Professor Yasergil teach us. You can see while he opened the dura, we can see another case with hemorrhage here. The sylvian fissure is narrow, and now we can see the frontal lobe. We open this the most of the time with the micro forceps, jewelry forceps, and we can open this. All the cisterns. The suction tube is important to be protected in the tip. I will forward a little bit. Obviously, the hemorrhage is an important point because we have some thrombus there. Now we are in the optic nerve. This side of the optic nerve. This is carotid. Okay. This is PCOM. And now we dissect the bifurcation. Okay, and A1. This is A1. We can see now the aneurysms. Fortunately, in this case, the aneurysm is forward, low, and very close to chias. Then we can dissect along of the A1. We try to go to the other side. We'll skip this, and we put the clip, and instantaneously the aneurysm was empty now. Okay, this is the CTA after of the clipping, and you can see the good position of the clip. Remember, the other place was hypoplastic A1 from the other side. Okay, I will speak this video only to share this kind of dissection. To me is very. I enjoyed it. What we with two microforceps we can discover all the ragnoidal layers here in the sylvian fissure, and we can see when movements to try to dissect. We don't cut the most of the time any venous system. We try to understand how can dissect with two tiny forceps and try to discover the veins. The vein system is very important to us because most of the time we coagulate these veins, we have transoperative edema, and the most of the time the neurosurgeons without experience, we try to dissect and finally they correct or coagulate the veins. This video is trying to show how we could try to understand the venous system and each vessel to don't correct and don't try to make an injury there. Okay. For another case, we have the infratentorial cisterns. Now, when you see the infratentorial cisterns, the most important, I think, is the several ponton cistern. Is very common. We need to understand the anatomy of this complex neurovascular complex and try to evaluate in the MRI or sometimes the cisternography to try to understand in which places you will operate. Now, sometimes it's to try to analyze the surgical corridor, the evaluation of the CP angle, the volume of the cisterns, and the anatomic variation there. The most common approach is the retrosigmoid approach. And this approach is very simple approach to try to put in the imagine of the brainstem there. And for to show this, this video is about a case of the trigeminal neuralgia and glossopharyngeal neuralgia in the same case. We evaluate with the MRI the volume of the cisterns. We put in the park bench position. We make a little bit semilunar incision. We have the muscle dissection, and we open the CP angle. You can see the 7 and 5 complex. This in the bottom is the trigeminal nerve, and in the inferior complex we have the cause of the glossopharyngeal neuralgia. We can see a loop of the pica. We come back to be better the dissection of the aneurysm of the neural layer, and in this case the neuralgia, the trigeminal neuralgia, we don't see any kind of loop of the ICA or superior cerebellar artery, and we decide to make an internal neurolysis. We dissect all the nerve in fashion, longitudinal fashion. We have the monitoring there, and try to dissect in this time. Now we will go to the glossopharyngeal complex. We can put this element is a PTF graph. It's a synthetic graph to try to isolate the lobe of the pica artery and put on the way over the glossopharyngeal nerve. We don't cut the glossopharyngeal, we try to protect, isolating the vessel. And you can see how the retrosigmoid approach, you can see all the superior, medial, and inferior complex here, and how to put this PTF tubular slip on the pica system. And you can see all the elements here in a really nice surgical panorama about all the complex here. Fortunately, the patient can any kind of injury. The pain stopped immediately, and the patient is very well and very happy without pain. Another for last, this is another case of CP angle case. You can see in T1 hyperdensity lesion here, and in T2 is the same. And we the selection of this because we are thinking in a cyst lesion. Then with this approach, we can see all the structures about this. This is opening the dura mater. We display the cerebellum, and we see the lesion, yellow lesion. We open the cistern. You can see a lot of tumor there. We try to understand how the CP angle is there. We try to dissect. There are not layers, and obviously try to don't make a damage there. The pica is there, and when we try to be a little bit superior, we try to dissect the medial complex. But obviously the tumor pushed a lot, and we try to dissect now the tumor. For us, it's not solid. For this purpose, is try to dissect the vessels and nerves, and you can see very close to the lesion. And we open this tumor and try to don't make an injury in the nerves. And we evacuate the cyst component to try to make a space. We don't have any kind of bleeding here. And at the end, we remove all the membranes inside of the CP angle. And you can see the vessels there. The adherents, you can see the fifth nerve, this complex. Too much membranes. And at the end, we can remove all these membrane. And at the end, we can preserve all the structures without any damage, and we can remove the membranes that contain that cyst. There is the other complex, and this is the end. How can remove this? We wash very well, and obviously the patient can the follow us very well. This is the 6 years after the surgery. The tumor was a narrow cyst, neuroenteric cyst of the brain. The conclusion is the anatomical knowledge and analysis of the studies is essential to propose the dissection strategy. The surgery is the tailored assessment of the fissure, and essentially to initiate the instruments must be sharp the most of the time. For microsurgery are mandatory. The surgeon must be sure of having them. In this, it is his obligation. Failure to do so will only result in difficult and frustrating dissection. And training microsurgery in live animals is a good path for delicate tissue handling. See, we need training and train and train. This is our laboratory in Mexico City. We try to, at the old-fashioned with Wistar rods and HCA to make this kind of dissection. And this is one of courses. And we can see this is the carotid of the rat. And we can make a lateral terminal with thin serous nylon. And obviously, this is fine of the path of the microsurgeon is making this 1, 2, 3, 4 times. But the most important thing is about this training with passion. Yes. And obviously, my conclusion about the role of microsurgery is only this way can thousands of the surgeons who live and care for patients in conditions where the technology that we desire is lacking, bring hope to those suffering a tragedy, such as having a parent, a sibling, or child with a tumor, aneurysm, or pain, and any other ailment that we can dedicate ourselves to. The legacy of Dr. Professor Yasergil must be preserved and transmitted in the greatness philosophy of microsurgery. It is our duty to teach the new generations the greatness of his hands and the minds. Gracias. Thank you so much. Thank you, Dr. Sameh Al-Morsi.
Thank you, Professor Ayla, for wonderful presentation. Is there any question for Professor Ayla?
Thank you so much, John Bennett and Dr. Atabati. Thank you so much.
Thank you for coming, Dr.
Thank you. So our next speaker is Professor Salim Abdul Rauf, distinguished name, skull base and neurovascular surgeon from US, George Washington University. Please, Professor Abdul Rauf, please.
Thank you so much, Professor Barty. I'd like to thank Professor Sameh and for the invitation. John, you do an amazing job for neurosurgery and all you do. Of course, very distinguished guest here, masters of neurosurgery, all are here. So I'm honored to be here to speaking with you. I'm going to go ahead and share a screen. It's very hot in Washington, D.C. It's been 90 degrees last few days. Okay, so let me start here. So this year, 2025, last few months, it's been the 100th anniversary for Professor Yasergil. And I've had the honor to give a presentation, which is about an hour presentation about the lessons I learned from him. But of course, this is a very short session. So I'm going to just pick a few ideas that I want to share with you at this occasion for this, time that there's a few ideas that I want to, share with you as to the process I went through and so forth. So, let me see how I'm going to put this. So with Professor Yasergil, I think is unique. Multiple generations of neurosurgeons were affected by him, okay? And there was a time in the United States where essentially every chair, I believe in the 70s and 80s, it was rite of passage for people to become chairs to go to Zurich and spend some time with him. This, I believe, speaking to Spessler and Duke Sampson, all those guys, all did that and so forth. Spend time in the OR with him and so forth. And a lot of the people who trained with him in Zurich actually did a lot of the opening and closing for him as well, instead of just watching and so forth. And I had a very unique and humbling experience with Professor Yasergil, and I'm very humbled by that. I had the unique opportunity, not only just open and close, but actually I got to do surgeries with him, microsurgery. It was just a time how it worked out for me. He took me under his wing, because I had attending privileges or internationally known as consultant, I had my own patients. So he honored me to actually, when I was doing surgery, to come in, to be in the room, scrubbed in, to be on the microscope. It was very stressful, okay? At the time, I cannot tell you how tough that was for me, okay? I was just a young neurosurgeon, just starting out, okay? The last thing I needed is somebody, a giant like him in the room. Because if something went wrong, I was very, very scared, which happens, starting in vascular surgery, things happen, you can't control. It scared the heck out of me. What really helped me is shown in this picture. Diane Yasergil was in every case with me. She gave me the kind of confidence no one else could have. So she and I had this deal. So he's on one side, she's on there. And when there's something, I look at her and she gives me a look and she gives me a gesture to tell me what to do next without saying anything, okay? She really took me through a very, very tough process, but that process made me who I am today. It was the most valuable experience I ever had in my life. It changed who I am. And at the time, it was very hard, very, very hard for me. I struggled with it, I'll be honest with you. It was not easy. But you know, I would not give it up for anything else I've had as far as training is concerned. Okay. So let me take you through one of my first experiences. A patient who had 3 aneurysms, ruptured aneurysm. Residents called me up. You know, I had just done my fellowship in vascular neurosurgery. Yale. I came, and so I got to know Professor Yasergil. So he said, okay, let me see how you do your cases. So I get this, one of my first cases, I get a patient with 3 aneurysms, MC aneurysm bled, grade 2 hemorrhage. I spoke with Diane. She told me exactly how to set it up, not to upset the professor. I have to do it exactly, the prep, everything exactly how he wants it, okay? So here I am in the sylvian fissure. So he came in. By the time I opened it, he was in. Now I could tell when he's in the room, everybody's quiet. You don't talk. Nobody says a word. Okay, you do not talk. Okay, so imagine I'm this junior resident who's scared at this point, and the junior attending. They got a couple aneurysms here. I'm in this sylvian fissure. This is the main aneurysm. Okay, so he's looking at me, and I'm just working this thing. The M1 is down here. So he sees I'm working around this perforator, and I say to him, and now he's in the room. What I'm really scared about, I'll be honest with you, if this aneurysm ruptures, I was not experienced enough, and I would be very nervous. And I was worried with him there. This is a ruptured aneurysm. If it tears, would put me in a difficult situation. So I was being very, very kind of uptight about the whole situation. So I say to him at this point, well, this perforator said, Professor, I think I'm going to go ahead and maybe let me just put a temporary clip on this M1 and I'll work it. He says to me, no. He's sitting right next to me. He says, no. Nothing else, just says no. I'm like, okay, all right, keep working. So I say at this point, I say to him, Professor, this perforator is really stuck. I think what I want to do, I just want to put a clip on the aneurysm down here. Then I can look at the perforator because I'm really, I didn't say to him, I'm really scared about the aneurysm rupturing. He says to me, no. He said, you keep working. Essentially, he told me, do not put a temporary clip on, which adds more stress to my situation at this point, okay? So he wants me to see how I'm going to dissect this perforator attached to the dome of this aneurysm, okay? So I say, okay, that's fine. I mean, so I keep working. As we go here. So essentially, he wanted me to really have the confidence without putting any clip on. See, these are the other 2. He told me at this point, just before he continued, just look at that carotid bifurcation aneurysm. Just have a quick look at it before you continue. I said, fine, Professor, I'll do that. I went down there. I looked at it. I don't know exactly why he asked me to do that. That's fine. Then he says, okay, keep working. Okay. So I'm working, and, I keep looking at Yasergil. She says, fine, just keep going. It's okay. So he wanted me to sharply dissect this thing of this aneurysm, and did not want me to be putting any clips or anything like that. Fine, okay? So he gave me the confidence, and at this point, I kept to dissect this perforator, and luckily, I was able to dissect it off, and, and then, of course, then it was very straightforward. Came time to clipping the aneurysm. I told him, and then before I clipped the aneurysm, before I had it dissected, he told me to go ahead and clip the carotid bifurcation aneurysm, which I did. I came back to this aneurysm and said, Professor, let me put a temporary clip on before I clip this aneurysm. He said, you don't need to. You're okay. All right. So I then go ahead and clip that aneurysm, and luckily things went well. And that was okay. That experience, while I lost a lot of sweat and a lot of fluid in my body during that time doing this, taught me a lot that under pressure, you need to be able to operate. You need to be able to do what the professor is telling you. You have the confidence, and if something bad would happen, he would probably switch seats with me or whatever. So that was one of my early, and he and I went through a lot of aneurysms and AVMs. It's the same process. Nothing got easier for me when he was in the room, okay? I was really nervous, but we went through a lot of cases together, and having Diane there really just helped me quite a bit to get through that process. During that time, and early on during that time, I was exactly, I know where I was standing. The residents just called me up. They said this patient with PCOM aneurysm was ruptured. And so I ran into him in the elevator. We were on the 5th floor, the OR, the two. He said, okay, I heard about this aneurysm. What are you going to do? I said, it's just a standard PCOM aneurysm. It's pretty straightforward. Essentially, I told him, I was just like, how it is. You've done your chief residency. You think you know everything. I said, it's a pretty simple aneurysm. He turns to me, he says, perhaps simple for you, but not necessarily for me. I was frozen in my spot when the minute he said that, okay? I think he sent me a very strong lesson. It's like, don't underestimate things, okay? You young buck, okay? And only took me years to understand what he said, actually, after that. Sometimes these, what appears to be a simple aneurysm, problem with PCOM, the neck, it's like behind you. You actually don't even see it. Something happens, if it tears or something, it's a disaster. And at that time, I was not mature enough to really make a statement like that, okay? But that statement from him was very educational for me personally. Move forward many years, a few years later, now I had moved to St. Louis, started my practice. One of the things I watched him do in many cases were together. There were these tiny little baby aneurysms on the carotid, tiny baby aneurysms. He would take his bipolar and just bipolar the damn thing. I had never seen that before. I was fascinated. You could do that, okay? So as I started to develop my practice, this is, for example, again, MC aneurysm, M1, right side. Of course, you could do a technique by stacking clips, and that's a great technique. You do it. Of course, when you have calcification stuff, there's a risk of the clips slipping, or you could tear the aneurysm. But people who are really masters at that, I know Mike is here and many other people are versatile in doing that kind of thing. So I started thinking, I wanted to just take what I saw from him to the next level. So I thought, instead of me stacking clips, I was going to just take that technique to the next level a little bit. So you see what I'm doing here? I'm just going to reconstruct the aneurysm, okay? So I started the process of taking some of these complex aneurysms and reconstructing them with the bipolar. Right there, okay? Just like that. In the beginning, when I started doing that, I used to always put a temporary clip on, but once I got really good at, comfortable with it, I'm comfortable doing this from that standpoint. So what happens with this is that you essentially reconstruct an aneurysm that may require multiple clips. Dr. Bhatti, is that your daughter? Is that a future neurosurgeon there? Okay, all right, we got a future neurosurgeon, guys. All right, so once the aneurysm is smaller, now it's so straightforward to clip this aneurysm. So I felt that I learned something from the master himself. I took it to the next level. And a young neurosurgeon who's the daughter of Professor Bhatti will also probably come up with new ways of even advancing this further, okay? So this is, so taking something from your mentors and then pushing the envelope and taking it to the next level. This next case really changed my career, my life, and really what I would go on, in neurosurgery. So I'm going back in time, front and back. So I just went back when I started my own career in St. Louis. Now I'm going back to Professor Yasergil. I'm a junior faculty guy, really interested in vascular. I started to do some anastomosis in the lab and stuff. I knew about his work with SDMCA bypass. So I'm doing the stuff in the lab and so forth. And the residents called me up about this patient. Okay. This patient comes in to the emergency room. It's about 1 o'clock in the afternoon. He's got ophthalmoplegia, mostly a 6th nerve. He can't move it on the ipsilateral side. No headache, just ophthalmoplegia. And of course, traditionally, you were told that these aneurysms, cavernous aneurysms, mainly the cavernous sinus thing. I go talk to the guy, very nice guy, his family, and after the one of the nice neuroradiologists do an angiogram for me. And I go speak to Professor Yasergil. He says, okay, what are you going to do? What are your options? I said, Professor, we could, there's enough evidence in the literature. You could occlude the carotid artery, he may tolerate it fine, whatever. Of course, now I'm interested in vascular. I want to do one of your STA-MCA bypasses here. Then I want to occlude the carotid artery. He said, okay, that's a good thought. You've been working in the lab. Why don't you plan on doing that? Schedule it for the next few days. Diane will help you set up everything you need. I said, fine, great. I go to talk to the guy, speak to his family. He's admitted to the floor. He's doing fine. At 1 a.m., I get a phone call from the chief resident. He said, you're not going to like what I'm going to tell you. I said, well, what's going on? It's 1 in the morning. He said, the gentleman, X his name, is fixed and dilated. I said, are you for real? He said, yes, I'm really sorry, but that's what the resident just called me on the floor. I rushed down, I drive to the hospital. The guy's fixed dilated, he's dead. I was just shaken up by this. Next day, I dragged myself to go see in the path. So what happened that this aneurysm tore through the cavernous sinus into his temporal lobe. Remember what we have been told throughout our training and our understanding, that these aneurysms do not kill you. They cause ophthalmoplegia. These are cavernous aneurysms. And not true for giant aneurysms. And I think, we need to rethink that, because this aneurysm clearly did not cross the clinolal segment. It did not cross the rings, right? I was really shaken up by this. This is early in my career. A guy I just met with his family. I'm planning to do elective surgery, is suddenly dead on me. I was really, really, I have to be honest, I was very shaken up by this whole thing. So, within the next day or two, Professor Yasergil could tell I'm really kind of, down about the whole thing. He said, what are you going to do? I said, I don't know. I want you to do this vascular thing. And he says to me, bad things happen. What really you have to think about who you are and what you're made out of. Something bad happens. What are you going to do next? You're going to just give up? That's it? It's done? Essentially, he told me, you got to be even better. You got to get better. You got to advance this more. Yes, bad things happen, but he really pushed me at that point. He didn't want to see me down. He said, no, this is not acceptable, okay? You got to show us how you're going to do the other cases that are coming up. Fast forward, back to the future, a few years later, now I'm in my position in St. Louis. Now I started to work quite a bit. At this point, I'm doing some high flow. The generation before me and Mike and the other people here, Spessler and those guys were doing these saphenous vein grafts for giant aneurysms, and I tried some of these saphenous veins. I really struggled with it. I had a problem with some of the valves, and I was having a problem with reversing the graft where the bigger side is in the cranial end. I had a couple bad cases, and I'm like this. So this patient is sent to me, originally thought to be a meningioma. Then, of course, we did the angiogram. It's like about 8.5, 9 centimeter aneurysm. I call, and at that point, by the time this case came to me, actually, and just take you back, I had a few cases I had problems with. I had called Professor Yasergil about this. I said, I'm really struggling with the saphenous vein thing. I'm talking to the cardiac surgeons in my hospital. They're using more and more radial artery. He said, okay, why don't you go and scrub with them and see how they're using the radial artery? How are you going to learn from that? So I decided to go scrub it. I scrubbed in a number of cases with the cardiac surgeons using the radial artery, okay? So what I did is I really learned how to use the radial artery from the cardiac surgeons. And I was getting ready to the first case with the radial artery, and when this patient came in, and I had those conversations with Professor Yasergil. So this was my first case with a radial artery in this patient. We reconstructed, we bypassed, and we were able to reconstruct the aneurysm, and we published that and so forth. So this was the transformation to the radial artery for me. And because we were doing these courses for many years, a number of colleagues here were faculty there. Every year, bypass course, we really pushed the radial artery. And I believe most people are using the radial artery now from that perspective. And I think many of our seniors pushed that as well. So that was great from that perspective. Next comes something that my interest in bypass and got stronger. And I'm doing these bypass surgeries, radial artery, all the way from here to there, whatever. And two things came to my mind as we're, this is a big operation, big incision in the head, neck, arm, long incision, whatever. I was doing a lot of middle fossa. I do skull-base surgery tumors. I ran into the maxillary artery. Then because I used a lot of Yasergil books, I kept looking at this picture. This is from his Yasergil, from his book. I'm looking at this massive vessel, the maxillary artery. I'm like thinking, okay, if you could go from here to there, why not go from here to here? So I call up a professor and say, listen, in your book, you did all these angiograms and stuff and so forth. The maxillary artery, he said, has never been used for bypass. I said, how about looking at it? He said, you need to go to the lab, do a lot of studies, look at it, look at how you could utilize it, and then we could talk about it, okay? So this is a maxillary artery below the middle fossa floor here, okay? So we did a large study based on the recommendation of Professor Yasergil, my team, my fellows and residents. We did a large number of cadavers. We made all kinds of measurements. We figured out how to expose it, essentially the idea was to bring extracranial to intracranial. So essentially the idea was for me is what Mike Lawton calls intracranial to intracranial bypass, meaning bringing the vessel intracranially and make an intracranial to intracranial bypass, okay? So I wanted to convert the maxillary artery into an intracranial vessel, all right? So that was, the concept. This was the first patient ever to have the surgery. This is the middle fossa floor. I had exposed the maxillary artery. I brought it inside cranial cavity. So the maxillary bypass is actually intracranial to intracranial bypass. That's really what I believe it is. And that's what was the original idea. So it's not EC-IC that a lot of people, it's actually, that's what I defined it as when we first, started this whole thing. Okay. So that's the first patient who had this operation. This was cover page in neurosurgery. One of our masters and another mentor to a whole generation, Bob Spessler, in his book, Bypass, he's the one who labeled it the Abdorf bypass. I'm totally humbled to have a person of his stature to do that. So with Professor Yasergil and Donahue in the late 1960s, they started the first microsurgery course to have people to come and hands-on train in microsurgery, in tubings and in rats and stuff. We continued that legacy for years. We did the bypass course, I had Yasergil there as well for one of them. Many of the senior guys in this talk have been there various years. Yasergil came there as well. So we continued the legacy that started by him, not by me. I did not invent this thing. I just want to make sure that's it. Okay. Then finally, when you talk about aneurysms, what was bothering me, what really affected me later on with aneurysms as I was doing my practice, there are those few cases that bothered me. Everything went perfectly in the case. The case, the ICG, the monitoring, the patient wakes up with a deficit. I'm scratching my head what possibly can have gone wrong in that case. As I'm looking at that, looking at the data of intraoperative neuromonitoring, you have up to about 20% of the cases, you're getting false positives or false negatives with MAP or SSEP. That's not 1% or 2%. Most complications we talk about this is a pretty significantly high number of patients you're giving the wrong data during surgery. My understanding was at that point that there's something with this that's happening that are giving you the wrong information, or you're getting a false positive where everything is fine and they're telling you something is wrong, and suddenly you're reconstructing something that you should not be messing with, and suddenly you create a problem falsely. So I felt that subgroup of patients that were having a problem was related to this issue. Okay. So this to me was a missing link. How long you can keep a temporary clip on? How do we know with the numbers I just showed you about intraoperative neuromonitoring? And if that perforator is behind you, you cannot visualize How do you know that your parent clip or clips did not incorporate tiny purple area behind you if you are getting the wrong intraoperative neuromonitoring information? So that to me was the missing link in some cases, you know, not a large number, in some cases. So that led me to the next step. So this is like Professor Ayala was showing these PCOM aneurysms. This is a patient with a PCOM and anterior choroidal artery aneurysm. So this is a PCOM aneurysm, right side, carotid, optic nerve, PCOM, anterior choroidal. You see that's anterior choroidal artery here. Perfect. The PCOM, no problem. You put a clip on it with your eyes closed. I wouldn't say that to Professor Yasergil, but that's fine. Okay, so that's fine. Now the anterior choroidal, it's a different ball game. You see, the choroidal's right here, but your tip of your clip is going to be behind you. You do not know where this choroidal is looping behind the aneurysm. There is no way you can see it, okay? So there is a blind portion to this procedure as your clip tip are going there. Could it be at here and behind me here and I've got my clip on it? How do I know for sure? What if my monitoring is wrong for a choroidal artery? Okay.
My hand.
You see, this is what I'm doing. As I'm closing the clip, I'm checking for anterior choroidal artery right away. Within seconds, I know the answer. Based on our data, you will know within about 60 to 90 seconds if there's a problem. We have a large data now. We've collected very big. It's all gonna, come out here. So we know for sure that, to me, this is a gold standard because we've compared this, all the cases we've done prospectively, we have intraoperative monitoring. All the monitoring for every single case are part of the study. So we, so I can call this is a gold standard because it tells you the true information. We have not had any false problems with the awake testing with all these patients we've done now. Okay, so to me, that was an area that I was very interested in. Similarly, the same problem occurs in high flow bypass we talked about. When you do the bypass, you're temporarily clipping the recipient vessel. Well, if you get wrong intraoperative neuromonitoring, how long would that parent vessel is tolerating that temporary clip? Do you know for sure everything is okay? That's one. What's the second? Once you have done your bypass, you're going to close somebody's parent artery that they have lived with their whole life. And most of the patients we're doing this on have failed balloon occlusion tests. Do you know that by occluding that parent vessel, everything is fine, your graft is perfect, and no problem? Or could there be a problem and you do not know about it because your monitoring is not 100%? That was so let me show you very quickly. I know I'm timing myself here. So that's a maxillary artery. We're going to use the maxillary artery here. So this is a setup. You have the radial artery graft here under regional anesthesia. We do everything in parallel. So we have three things happening: the radial artery graft, the cranial opening, and the neck opening for final occlusion of the carotid, because we're going to use a maxillary artery, okay? Fellow, chief resident, and a faculty partner, all working at the same time, okay? Where's that? Okay, so first thing is we're going to attach the vessel to our now intracranial. We move the maxillary artery intracranially, okay? This is not a problem. Temporary clip and maxillary doesn't supply the brain, so you're not worried about it. There's no problem. This step is not an issue, okay? So here I'm attaching it, fine. Now we're going to check the flow of the maxillary artery. Great stuff. I'm very happy with it. Fine. Now those two steps come in. First step, I've got the option of 3 M3s in this patient, okay? What I'm going to know which one is going to be the safest to temporary clip for the anastomosis. I'm going to do the test that I have now done, and I know. So I'm going to temporary clip this one, okay? And I'm going to test the patient for
there,
10
my
minutes.
hands. Perfect. There you go.
We're watching everything. Patient is fine. That means she's got enough collateral flow for that one, okay? Now I'm attaching the vessel, patient awake, we're talking, you're happy, you're not freaking out, everything is fine, all right? Now you get your ICG, okay, everything is good. Now you're gonna make the big step of this lady failed her balloon occlusion test before surgery. What am I gonna do? I'm gonna occlude the carotid temporarily, okay? Now I'm gonna do a 10-minute test with a hypotensive challenge, and I'm gonna essentially test the graft with no doubt okay, for 10 minutes.
Deborah, squeeze my hand again. Deborah, squeeze my hand one time.
All of us in this call, you know, we occlude a lot of carotids or vertebrals for bypass. You're praying when you're occluding them under general anesthesia because you really do not know 100%. You think you know, but there are situations you do not know. Here, I know 100%. There is no doubt what's happening here.
All right, there you go. What you talking about, bro?
We've had cases now, we've had a problem at both ends. We've had a problem with temporary occlusion, the patient didn't tolerate it, and we had to go to another vessel. I had two patients, the bypass looked good, I did the temporary occlusion, the patient was having a problem. One patient was having a problem with his speech, was on the left side, the other patient. Once I investigated everything, one of them had a pretty big kink that I had not seen. The other one, this distal stenosis, the mouth of the anastomosis was too small, I had stenosed. I had to use a running stitch. And it was just stenosis when you really observe it, and I had to redo it. And the next one, the patient, and then the patient did fine once I did. So I did catch something during this process. Okay. Anyway, so when we started this process, the IRB told me this. You do 30 patients awake aneurysm clipping. You do the 30 patients bypass for complex aneurysms. You show us the data before we let you continue further with this, okay? So these were the first 30 patients compared to large data banks in the United States of under general anesthesia of clipping aneurysms, and these 30 patients did better than the general anesthesia arm, you know, all experienced surgeons and so forth. Same thing, I compared my 30 patients with my 110 general anesthesia patient bypass, they did better, okay? So with this phase 2, we looked at these patients that we did. This study was only allowed for complex aneurysms, okay? Large, giant, calcified, fusiform, coiled, stented previously, or coiled and stented. So when we looked at, and this was, the outcomes of this was done a separate committee, not neurosurgery department, through electronic health records. So we were not involved in collecting this data. When you look at the data of these patients, in our study, we had 2 arms, and the patients were given the option. 40 patients elected a general anesthesia, 162 awake. You could see there is a significant difference in outcomes. Same team, same anesthesiologist, same surgeon, same everything, okay? These aneurysms here, okay? And that's in general anesthesia literature, neurosurgical literature, you know. So we feel that there is something here for sure, you know, with the studies continuing into phase 3, that there is something to say about what we're doing with the awake that is affecting outcome from that perspective. Of course, on this panel, there are very highly experienced surgeons, and, you know, in their hands, probably everything is okay. You know, I just do believe, you know, this may add, you know, another armamentarium from that standpoint. Finally, as we're talking about Professor Yasergil, just a larger perspective, when you know, for the 30th anniversary of the Neurosurgery Journal, he was asked to talk about ventricular tumors. I spent weeks with him learning about intraventricular tumors, and although I learned so much from him from the operating room, but the times and the hours and the days I spent with him discussing every little thing allowed me to an insight into his brain. I can never be like him. He was completely visionary. But I got an insight into how he thinks about all these things, and this helped me a lot. And in this manuscript, you know, we really discussed a lot of things. Before I was with him, I was trained to get into the ventricle, to the third ventricle through various trajectories. His cisternal thinking completely changed my attitude. For example, dysmeningioma in the third ventricle here, going, you know, intrahemispheric, transclosal, and then through the sulcus here, that's the fornix right there. It's keeping the fornix safe and sharply opening here allows you, so all this stuff that I believed in, intraforniceal essentially injure both fornices by the bottom line, okay? So I learned the cisternal ways of getting to places without injuring neuronal structures, okay? And this is using the CUSA inside the tumor here, and this is inside the third ventricle. After I opened it up there, okay. Anyway, so that's the post-op. Anyway, for AVMs, really, it was a huge learning curve for me in AVM surgery with him. I just want to show you one case that combines everything I'm doing here. This is a very there's all of us have patients you never forget, and this is one of them. This is a guy who at the age 11 had an AVM bleed. He had radiosurgery, he had multiple embolization on the East Coast, and then he had another smaller hemorrhage. He had another radiosurgery, more embolization. At age 21, now he had a number of deficits on one side of the face. He had less hemiparesis, but fully, really functional guy, you know. He has this hemorrhage in his brainstem, all right? So now I'm asked to look at this, you know, from that perspective. I don't believe that these Spencer Martin grade 5 AVMs that are purely in the brainstem are operable cases, okay? And I would never operate on them. I'm showing you one exception. That's it. I'm just showing this as an exception. I spoke with this family. He's been through this all the years. He had this hemorrhage. He was in the ICU for 2 weeks. He started to wake up, but out of ventriculostomies. Now he's waking up. At this point, I had the courage to have this conversation with the family that, you know, we could, you know, he's been through this process for 10 years. We could potentially look at this from a surgical perspective. This is all intraaxial AVM in the pons, okay? So you see the vessels here, or the drainage is along the basilar plexus up here anteriorly. I'm a product, as we say, with standard shoulders of giants, people who have really taught me what I know today. To get to this, I really learned from Professor Al-Mefti. How you get to an area like, you cannot get to this through a standard approach. You're going to be in a really bad situation. Essentially, in this case, this guy had no hearing on this side. I had to do a transcochlear approach, which I had learned from Al-Mefti. And in Michigan with Malik, I learned so much about AVMs, of course, then with Professor Yasergil. So I'm a product of great minds, you know. So this is the view you get from this amazing entrance. You have the 2 vertebral arteries, the basilar artery, the 6th nerve, okay? So brainstem AVM is a different ball game. You're gonna have to follow the feeder all the way until it enters the pia. You cannot take it more proximally, of course, for obvious reasons, right? So this is the large draining vein here. You see there's a little bleeding, and I'm just gonna control it right there. Okay, this is a branch of pica coming, so I'm gonna follow it all the way until hard. Every time I'm gonna take a vessel, I'm temporarily occluding it first. I'm testing the patient. I'm talking to this whole operation. Every vessel I'm concerned about, put a temporary clip on, I test the patient. Awake surgery is amazing for AVMs because it's an all or none thing. If the patient is having a deficit, there is no way that branch is an AVM vessel. If he's having no deficit, it has to be an AVM vessel because AVM direct feeders do not supply normal brain at all when they enter the nidus, right? So it tells you, you know, it's an all or none thing. So this technique just is a game change for complex AVMs right here, okay? So then when he tolerates it, I can take it, okay? So throughout surgery, I'm testing all kinds of things and all 4 extremities, driving crazy the whole time. That's a basilar artery, perforators coming out of the basilar, going to the brainstem, okay? Look at the approach. If you try to do this case in a standard approach, retrosigmoid, you would back out completely. There is no way, all right? So combination of skull base really is a game change in this process. And so just for time here, last draining vein, okay? And that's it, taking that vein. That's him. He's on social media all the time, posting about his AVM and so forth. He continued with his deficits, but he is cured now, okay? Lastly, just from things I learned from Professor Yasergil, you know, this is from him that he gave me this drawing of the cast of the blood. He was fascinated by cerebral blood flow. He was always fascinated by collateral flow. Every conversation was about that, okay? So here I was, you know, so that really got me very intertwined in it. And just to give you a glimpse of how that has it. So this is an AVM in the vermis in this patient. Anyway, so here is being supplied by multiple vessels, all right? So this is in a semi-sitting position on this patient. do an ICG to look at the things. So I'm looking at pica.
Yeah.
With the temporary clip, we're doing cerebellar testing on this patient for the same reason I showed you in the last case. If the patient is doing fine in all the tests, then that branch that I'm worried about, I can take it, okay? But the reason I'm showing you this for a different reason. This work has opened the door for us in neuroscience that we have never had before, which is we're looking at blood flow to regions of the brain in a way we have never been able to know. Remember, all that information we have in neuroscience and neurosurgery is from retrospective data. Patients who've had a stroke, whatever, then we know what the deficit is or whatever. This study, a secondary outcome is we're able to study these various vessels and their functions in a prospective fashion, something we, that's unique. And there's a large group of scientists who are working with me in this and collecting this data to understand especially the cerebellum, because you don't have any monitoring that tests cerebellar functions. So we are opening a door to understanding cerebral blood flow in a way that we had never imagined before. Anyway, when Professor Yasergil wrote his book, Microsurgery, which was really the essence of starting the field of microsurgery, he had Professor Cambiol, his mentor, write his foreword. When I wrote my BAPAS book, I had Professor Yasergil write the foreword, and I'm honored by that. What I learned from Yasergil in the OR is timeless, and it changed who I am. But also, probably so much I learned from him had nothing to do with the operating room. He was asked to write a lot of editorial comments about a lot of things in neurosurgery for various journals, okay? So he and I, this is all the things I wrote with him. The hours, days, and months I spent with him, and when you review a paper with Professor Yasergil, it's not like you're reviewing with somebody else, okay? He expects you to read it, you understand it, then he's going to ask you very difficult questions. And some of these papers, we spent hours discussing. Some of the authors of these papers probably are also on this panel here right now, okay? And we wrote the editorials for many of these. And this learning, by really getting into his mind and understanding about all these things over those few years, really affected me in how I look at the brain and in so many things. And to me, this was invaluable experience. Anyway, thank you. But what I want to say is this. My journey, this is after I spent that time with him, I started my job in St. Louis. He came to visit me. We were a division of neurosurgery. 10 years later, I became a department. In these 10 years, he came every year, sometimes multiple times every year, to check on me, make sure I'm doing okay, and make sure everything's going fine. So when we talk about mentorship, and he never used those words, it was implied in a way in his actions that he kept an eye on me in a way that he wanted to make sure that I'm growing in the way that I should be growing in my specialty. So that was profound for me. Diane Yasergil, the person in the background, so all those aneurysms I was doing when he was, so then I was doing a lot of aneurysms. When he was doing something, or was in the office, she was in the room with me. All I did, I would put, when I'm ready to clip the aneurysm, I'll put my arm up like this. I'm looking under the microscope. She knew better than me which clip was perfect for that aneurysm. She taught me, so she knew a lot better looking at the monitor what I needed, okay? So although we, of course, honored Professor Yasergil, I think if the phrase behind every great woman, a great man, there's a great woman, had not been invented, we would have invented it for Diane Yasergil. For me, she was a great teacher, and I learned so much from her in the operating room. Thank you for having me. It's an honor for me to speak about a man who really changed our field, father of modern neurosurgery, and I'm humbled to have been in some way taught by him and mentored by him. Thank you very much.
Very good. Ata?
Thank you, Professor Salim Abdurrauf. It's an amazing and inspirational, eloquent story. And thank you for sharing it with us. And it's a great tribute to the master by a neurosurgeon who's world renowned, and It's really, really heart-touching. Thank you so much.
Thank you, Professor Bhatt.
Is there any question for Professor Salim? So can I ask Professor Salim, how often you come across the manipulation vasospasm, or in a ruptured cases, dealing manipulation leading to spasm, and how you deal with it?
I think spasm happens a lot more than we think when you touch. Some people are more sensitive than others. So the key thing is, one of the things that the generation before us used to dehydrate these patients quite a bit. We don't do that anymore. I actually overhydrate my patients for vascular neurosurgery, which is totally opposite to my teachers from the generation before. Dehydration and hyperventilation, I'm the opposite. I give a lot of fluid, and as you know, in awake surgery, their CO2 is very high. It's the opposite of hyperventilation. It's high because you can't even control it, and I like that. You got maximal vasodilation. And I use papaverine intermittently, but a lot of times, yeah, you're right, Professor. It's, you see spasm quite a bit in these cases. And so, you do your best in that process in handling it for sure.
Thank you. Thank you, Professor. So our next speaker is Professor Michael Lawton. Professor is a renowned name, president and CEO of Barrow Neurological Institute, and a great teacher and author of 7 aneurysms, 7 AVMs, and 7 bypass. He's going to enlighten us about his experiences with the skull base ECIC and his thoughts for Professor Yasergil. Professor Michael Lawton.
Can you hear me?
Yes.
Yes.
It's great for me to be joining you. I'm not seeing a button to share my screen. Am I on the right?
It's the bottom green thing, Mike, in the.
Yeah, I know it should be there. It's not.
Oh, you're not seeing.
We need to upgrade him to panelist to see the screen sheet.
Yeah, I probably need to be pushed into the speaker room.
Yeah. Please accept the invitation that we sent to you on Zoom to go to panelist.
We've had this before. You might have to reboot, Mike. Do you have the latest version of Zoom?
Okay, John, could you please make me host and I will manage it?
Hold on. Okay, you're in. Okay, here we go. You're in. Yeah, okay, you should get it now, Mike.
Perfect. Now I have the share button. Perfect. Okay. All right, let me share my screen. There we go. You should see my desktop. And now let me just push this into the play mode. Yeah. Okay. Can you see that picture of Yasergil?
Yes, perfect.
All right, great. Well, thank you for inviting me. I appreciate the honor to be a participant here. And these talks have been great. Salim, nice talk. Enjoyed that. You have a nice connection to the master there, and I think that's very special. I didn't. I never really had an opportunity to work with him. We met actually at Salim's course in St. Louis many years ago. I think it was probably over a decade ago. Salim, as he said, would invite him to the course, and he was there. And we had some nice conversations. I remember a banquet dinner that we sat together and we talked. But I never worked with him. I did feel always like I had, though, because as Salim said, it was a rite of passage for people in the 70s and 80s to kind of go to Zurich, to spend time in his operating room and learn from him. So that included Dr. Spetzler, who trained me. So I was sort of like 2 degrees of separation from Yasergil, and always felt like I was trained by him because of Spetzler's affinity for him, and others. There are clearly many others who impacted me who also trained with Yasergil. But when I reflect on his achievements, it's amazing. You know, bringing the microscope into neurosurgery, the work he did to build the Contravis stand that allows us to use the mouthpiece and to have that microscope float, the introduction of bypass surgery, the instruments that he developed with the forceps and the bipolar coagulation. I mean, all of these things are just incredible. It reminds me of Elon Musk, someone who not just excels at one thing, but is able to excel at about half a dozen things at the same time. And I think that's truly unique and truly special. And not only did he do all these things, but he was very good about writing them down and publishing books. He's been an inspiration to me that way. I think writing books is important. You kind of get lost in the papers. So to actually take on book projects and put all your thoughts together collectively, and to stay with an idea from the very beginning through all of its different ramifications and branch points. I mean, that's a real effort. And he did that with his microsurgical volumes. He did it with vascular, he did it with tumor. And I've certainly, I think of him when I write my books because, you know, what he did there in the 80s, I've tried to do in some of my books, which is just to stick with a topic for long enough to really to nail it down. This is just something I'll share. One of my illustrators, Peter Lawrence, did this nice portrait of the professor there on the left. I think that captures his look and spirit. And then I was actually at the Congress meeting, I think it was in 1999 in Boston, and he was named the Man of the Century, and they were passing out journals. So I stood in one of those signing lines, and you can see his handwritten signature on my copy there. It says to Dr. Lawton, best wishes, Professor Yasergil of Boston. So I do feel like, you know, that's my special trinket of his in our connection. That said, you know, I think the greatest tribute to a man who's had such an impact is to really carry on his legacy. And so that's the reason I was going to talk about skull-based bypass. And I'll just show you this table. It's very cumbersome, but it's what I categorize as the 7 different types of bypasses. And the first line is an homage to Yasergil. It was the first generation bypass, the ECIC bypass, the scalp artery to intracranial artery, classic ECIC that he introduced. And that really, I mean, even to this day is what most bypass surgeons do. And the types of variations that follow in life and in the table are just kind of journeys that people have taken from that seminal work. You know, the second generation and the second line, those are the higher flow interpositional bypasses that were championed by Thor Sundt. The next 4 lines, 3, 4, 5, and 6, those are what I call the intracranial bypasses. These are the fun bypasses in my generation that we try and do that rely on the same anastomotic connections that have been around for a century, but just doing them in new and different ways. And I'll basically talk about that for this lecture. And then the last row at the bottom is the combination bypasses, where a single bypass isn't enough. You need a double or a triple. And so the combination brings together any of the other bypass constructs, be it an ECIC, an interpositional ECIC, or one of the ICIC bypasses. So just to kind of dive deeper on the ICIC, which I think, you know, my point is that Yasergil didn't do a lot of these, I don't think. He wasn't known for intracranial bypass. And this has allowed us who followed him to kind of take his teachings and move it to a next level. And so that's really what I wanted to focus on as a way to kind of thank him for that. So reimplantation is really, you know, your classic end to side bypass that takes an artery from an aneurysm and reimplants it on a parent vessel that's typically distal to the aneurysm pathology. So these are just some illustrations that show ways in which we reimplant, and you can reimplant a pica onto the vertebral artery, the V4 segment. You can reimplant an anterotemporal artery down to the SCA as a donor reimplantation. There's some really clever, fun constructs that allow you to reimplant and revascularize in that manner. The in situ is your classic side-to-side bypass, where two vessels, a donor and a recipient, that run parallel to one another can be attached and communicated. It creates these communications that allow donor to recipient flow. The classic is the pica-pica bypass, which I've shown in this illustration. Plenty of room in the cisterna magna to sew, but as I'll show in this lecture, there are lots of variations there. Reanastomosis is another great one for vessels like pica or like the MCA that have redundancy. You can bring ends of arteries together after you excise pathology, and that end-to-end reanastomosis is a really good, easy way to revascularize without the need for a donor harvest. And lastly is the short interposition bypass, where you run a vessel typically from like the M2 down to the PCA for an M2 P2 bypass. And these short jump grafts are really nice ways to do a little higher flow and bring vessels together when you are not just resupplying one recipient, but a whole collection, like the basilar quadrifurcation, for example. So just some examples. The rest of the case is just some video examples to show these. This was a lady who was in a ENT office and had a procedure for a biopsy in her sinuses, and they got right into the carotid artery. So they asked us to take care of her. They shipped her over. She had a Foley in her nose to control the bleeding. And in order to take that out, we had to first revascularize the carotid so we could trap that dissected segment. And you can see here, I'm showing this cephalic vein to the supraclinoid carotid. The cephalic vein is what we used because the radial artery was not available. It was damaged. So we took the cephalic, which was right next to it. And because it was so high caliber, so large, the supraclinoid was just a better sized recipient. And this is now the other end, sewing it to the common carotid artery in the neck. So this is your tunneled high flow second generation bypass graft that connects the common carotid shown there to the supraclinoid carotid shown here. And this revascularizes the intracranial circulation. Now the clip can go on the distal carotid at the level of the siphon. So that dissected portion is now excluded. And you can see there the CC fistula, the cross filling, and now the bypass that has reconstructed her carotid flow. So that's a nice example of a second generation bypass. The rest of these I'm going to focus on third and fourth generation bypass. I'll start with the pica. These are just a list of all the different pica bypasses. You can do ECIC with the occipital artery. You can do in situ, like I showed in that earlier slide with the side to side. But you can also do reimplants. You can do reanastomosis, and you can do interposition grafts. And I'll just show you this one here. This is a double reimplantation case. Look at this pica aneurysm. It's got two outflow arteries. It's a little bit distal on the pica. So for this, my strategy was to trap the aneurysm, excise the pathology, bring the parent artery together end to end, and then take that accessory branch and reimplant it downstream on the distal pica. And that would reconstruct it. Now we had a problem, which is shown here. The first anastomosis did not take, and I'll show you why. And so I had to bring the trunk of that pica to the vertebral artery, the V4, and reimplant that side to side. So that's a side-to-side reimplant plus a end-to-side reimplant of the branch. So let me show you that in real time here. This is now the pathology that you're looking at. You can see one branch coming out of there, and you'll see the second branch here in a minute. But here I'm excising the aneurysm. There's the second branch just deep to that. And here's the trouble. The parent vessel was diseased, and I didn't cut back enough of the
parent artery to get back to normal healthy tissue. So when I sewed in this end-to-end reanastomosis, it looked good initially. There's a little platelet aggregation there, but I continued on. I'm now showing you the distal reimplantation. So that branch artery is going on to the distal pica, which you see there. And that's just your classic end-to-side. So the red is the end-to-side. The first one here is the end-to-end. I'm trying to reopen this, but you can see it's hopeless. There's too much thrombus there. There's no way to do that. But luckily, you see the redundancy in that pica. I was able to pull that loop of pica upward to the vertebral artery. So this is the vertebral artery here, and this is the pica. I'm bringing them together side to side. So this is a reimplantation using a side-to-side anastomosis. So this is what I would call a fourth generation, because it's a reimplantation, which is a third generation bypass. But because we're reimplanting with a different kind of construct, a side-to-side rather than an end-to-side, it makes it a fourth generation. It's another level. So there's an example of this double reimplant with a good result in this kid. Oops. So this is another case, another pica case. Picas are great because you've got so many options. But look at what nature gives us here. It's a double origin pica. So we're going to trap this ruptured aneurysm. We're going to use one of the origins of pica, swing it over to the distal, and you can see it provides nature's own jump graft. It's like you're creating a little fenestration around the aneurysm with this jump graft. So that's a nice little gift that nature gave us to provide us with that extra. And so here's the view in surgery. This is one origin, two origin. They merge together right here. The aneurysm is just distal to that. You can see thrombus over the aneurysm there. And like all these, I like to first clip because it's faster and easier. But you'll see this is a dissection. There's no secure tissue there, and the aneurysm just ruptured. The clip kind of slid right off of that fragile tissue. So we trap. It's a hole in the artery, which you're seeing right there. And now I'm incising the extradural pica as it comes through the dura. I'm going to use that as my jump graft. You see how it flips over and bypasses that segment of the aneurysm. And now with a little linear arteriotomy, I can reimplant that distal on the pica, which jumps the area of the dissection. So this is just an end-to-side reimplantation of that extra limb. You can see the fish mouth there. You can see the running suture technique, which I like. And there you can see our end result, which is our essentially a nature's jump graft around it. And there's the aneurysm that's isolated. So ICA bypass is next. Lots of options here as well. The illustration to your right shows the 7 bypasses framework, meaning that all of the different 7 bypasses that I showed you in that original table, we've done. We've done ECICs, we've done interposition grafts to the V3 segment. We've done all the 4 intracranial variations, and we've done double bypasses. So lots of variations to the ICA. I'm going to show you this one here. This is a nice old lady who had some brainstem or pontine compression from the this thrombotic aneurysm, and I'm going to do an ICA-PICA bypass. ICA and PICA were running close enough that I could pull them together. This is a side-to-side anastomosis in the cerebellopontine cistern, and you can see they come together beautifully. The idea is to use PICA to revascularize ICA, and with ICA revascularized with the bypass here, we can then go to its exit from the aneurysm, which is right there. You see its relationship to the 6th nerve, which is draped over. That was our distal clip occlusion. Right there, there's enough inflow to clip occlude the proximal part of the aneurysm. So now the aneurysm is trapped. And what she really needed at the end of the day was decompression of her brainstem from this thrombotic mass effect. And so there you can see the aneurysm's entered, it's decompressed, and this is our IC green showing backfilling from PICA to ICA. And there's our post-op showing good filling from PICA to the ICA territory. The SCA bypasses are shown here. This is one that's actually really favorable for ECIC because the STA provides a nice, easy donor. So I do use the STA a lot for SCA. But what I'm going to show you in this case is a S2P2 bypass, meaning we're going to connect the SCA with the PCA in the ambient cistern. This was a lady who had an endonasal endoscopic procedure for pituitary. This was at another hospital. They got into her P1 and dissected it with a hemorrhage, transferred her over to us, and this is now bringing the P2 together with the S2 so that the PCA is taken care of. I'm going to end up trapping this aneurysm. You'll see that in a minute. But this bypass is done first. It's to bring these two parallel arteries together in the oculomotor tentorial triangle, just on the edge of the tentorium. You can see the tentorium there. And you can see how nicely those vessels come together. So SCA is feeding PCA, and there's the conformation. Now, as we look at the dissection over here, you can see the basilar trunk, you can see the PCA, you can see just a little manipulation causes that to rupture. So you can appreciate why it's so important to think in advance of that maneuver and have everything ready. So that first clip is a trapping clip on the P1. This is a second trapping clip on the distal P1. And now the bypass takes over, and you can see how SCA and PCA are now communicated, and her flow is accounted for. The basilar bypasses are tricky. These are fun bypasses to do. I love doing these. These are some of the variations that we've done. V3 to PCA, M2 to PCA. This is the workhorse. And of late, we've been tinkering with the C2P2 bypass. We recently published this in Neurosurgery, if you're interested. But these are ways to basically revascularize the posterior circulation in anticipation of taking down a basilar trunk aneurysm. And this is just an example. This is an M2 P2 bypass. You can see the beautiful exposure that you get of the P2 in the oculomotor tentorial triangle in the crural cistern. And the interposition graft goes nicely down to the P2. I like the P2 because it's a meaty artery. It's always nicer to sew to a meaty artery in a deep hole. So I like going up to the P2. The S2 is a little easier, more accessible, but it's not as big. So that's the reason or rationale. But here we're sewing the deep part first. I always like to get the harder end addressed first. And this is an end to side implantation of the artery on the P2. And now what you're seeing here is the M2. It's a transsylvian approach down to the P2. So going up to the M2 is just an easy afterthought. So you just go pick your site in the sylvian cistern, and there's your anastomosis there. Nice view of the intraluminal side of the anastomosis. And here, just finishing this off, you have your M2 side. So this was done so that we could take down the basilar aneurysm. We did that endovascularly in this case. It's not the bypass that's the hard part, even though it's a deep bypass. It's the after effects. It's the takedown of the basilar and the sometimes uncontrollable thrombosis that you get with that can be challenging. So this was stage 1. Stage 2 was an endovascular takedown, and you can see that there. And these still are tough cases to get patients through that. Another case, this is a giant basilar aneurysm. It looked like this in 2020. A year and a half later, it looked like this. So clearly a tenuous situation. This is a example of a double interposition bypass. Again, M2P2 was the original intent. You can see the P2 here, and we're sewing into that P2 with our radial artery graft. Now, when I finish that, this is now sewing into the M2. What you're going to see really briefly here is that when we went to open up the bypass, what we found was that the graft had been harmed. And when we close the basilar trunk here and we run the IC green, we find an occlusion in the bypass graft, which means that there was trauma in the graft. So what you're seeing now is the graft has been cut out, but I've left a little stump of that graft in on the P2 just to pull this end-to-end repair a little further out and make it a little shallower. So that was the redo of the deep side. This is the redo of the M2 connection here on a different branch. And now this basically has two short segment interposition pieces, and we've reconnected it M2 to P2. So now there's the redone bypass graft. We go back on with our proximal occluding clip, and look at that flow reversal right here in the basilar aneurysm. So now the flow is going across the aneurysm rather than up from the basilar trunk, and that caused the aneurysm to thrombose nicely. And she's doing well. She's 4 years out now from this bypass, and she's doing well. Vertebral artery bypass, the V3 is a wonderful donor vessel. I'll just show you some examples of that. This is a lady with ischemic disease. You can see one vert here ends in pica with no distal flow. The other side also ends at pica with just flow to the pica territory. And she required revascularization of her mid-basilar trunk. So this is the view that you get of the V3 segment. This is the view you get in the cerebellopontine cistern. And this is ICA. So we're going to bring in a graft to ICA. And flow to ICA is going to allow the basilar circulation to get a little boost of flow that it's not getting from the vertebral arteries or from the PCOMs. So this is the anastomosis. We've got the deep layer done. Now we're doing the back wall here. And that's the completed connection there. And look how close the V3 is to that retrosigmoid exposure. It's a really nice way to get the V3 exposed. And we just plug that in here. Nice caliber size, good end to side anastomosis here. And now you can see this jump graft, radial artery. And when I show you the post-op angio here, you can see just how much more robust the flow is to that brainstem and cerebellum. And she has been stroke-free, TIA-free for many years now with this bypass and has done very well. Two more cases. This is a guy with a hostile neck. He had a tumor with a neck dissection, radiation. There's really no good flow or donor vessels here in his neck on the left side other than subclavian. So when he presented with ischemic events on this left side, we didn't have a lot of options. We either go down to subclavian and have to tunnel through that hostile area, or we go to the V3 segment. So what you're seeing here is sewing in the graft, a saphenous vein graft to the sylvian M2. And then we're going to run this from the sylvian fissure all the way down to his V3. Again, it's that V3, which is such a nice donor vessel right at the level of the sulcus arteriosus, which you see right there. He had incredible plaque within the V3 segment. So we first need to do an endarterectomy to clean it out. But now we have clean artery to sew into, and this is our donor anastomosis here. And now you're going to see the run of this graft that goes from V3 all the way across his cerebellum into the sylvian fissure and down to revascularize the carotid circulation. So it's a long jump graft, high flow, but really using what's available in an otherwise hostile neck. And then the last case to show you is this one. It's a binder ring bypass. The video kind of sums it up. When you've got a big artery compressing the cranial nerves and you're wanting to do a vascular decompression, the sling's not going to cut it. There's too much artery there. So rather than sling this and try and tuck it in more medially, what I'm doing here is I'm transecting the artery. I'm rerouting the artery to the outside of the 7th and 8th nerve bundle, which you see there. And then I'm going to sew this back together. So it's like the binder ring on a notebook where you snap it open, insert your loose leaf paper, and then close it again. It's the same idea where you're going to cut this loop of artery, you're going to reroute it around the nerve bundle, and then sew it back together. So that's what I call the binder ring bypass, and it's a beautiful technique. It allows the arteries to continue their pathologic trajectory. they can continue to elongate or dilate, but now the artery's outside the nerve, so there's never going to be any compression of that nerve bundle. And you can see how nicely that reroutes around the nerves and protects them. So that's the binder ring bypass. The post-op imaging looks exactly the same as the pre-op imaging. You can see how much redundancy there is in that native vertebral artery, and he did well. So that just sums it up. I like to think of this talk as plumbing as art. What we show in bypass surgery is really about plumbing, but there are many ways that you can do it. You can do it with simple techniques that are old and tried and true, or you can be creative and do the more artistic bypass that involves intracranial connections, different types of constructs, and I think it yields a field that's ever changing. I like to finish with this collaborative rivalry. It's fun because I think there's a pretty robust bypass community out there. There are a lot of us that like to do these challenging bypasses, and it's fun to just see who comes up with the next big interesting bypass. There's so many different so many other different bypasses to innovate out there, and I think it's fun to just have this collaborative rivalry together. So with that, I am done. Thank you for having me, and thanks for doing this for Dr. Yasergil. I think it's a nice thing that's happening.
Thank you, Professor Lawton, for your excellent talk, and it's amazing to see the next level of work you are doing and keeping this art alive to a new level, new heights. And your mentorship is such an inspiration for everyone in the coming generations. Thank you,
Professor
so much.
Bhatti, can I just make one comment, please?
Sure.
You go around the world and people say, after Yasergil was the end of microvascular surgery. He did everything that was done. And that is actually not true. He contributed quite a bit and gave us a foundation. What Mike Lawton is showing is something most people are not aware of. And especially when endovascular people speak at conferences, say, microsurgery is this old thing. Everything was done 20, 30 years ago. We're developing these new stents. I think contributions of people like Mike Lawton show that it is a very dynamic and continuing microneurosurgery, microvascular surgery is live, it's evolving, just like all other technologies. I respect Professor Yasergil, he was my mentor, but that was not the end of microvascular surgery. So I think the young generation needs to know that, and perhaps more importantly, the endovascular people, in their big presentations, they always say this. This was done, in 2000s and 1990s, and we're doing. It's just not true. It is evolving at every level, and and having people like Mike, to be such a leader, I think it's so important for our specialty, And I think, we want to continue what was started by Yasergil, to be alive. If it ends with him, then he did not achieve what he wanted. So I think this is important to say.
Hear, hear. Well said. I think, he gave us insight and technique, and it's like sports, the athletes of today are just so different from the athletes of 30 years ago. They jump higher, they skate faster, they throw the ball further and harder. And, the sports evolve, the superstars just get better. And I think the same is true in surgery. We can take what Yasergil taught and just move it on to the next level. And bypass is such a great form for that because it's not deconstructive. I took out 3 AVMs this week, and there were some real nasty ones. And it probably doesn't look any different what I did on those 3 cases than what Yasergil did 30 years ago. But in bypass, it does look very different because when we're doing these S2, P2 bypasses or these V3 bypasses, those are things that have come around in the last 10, 20 years, and not a lot of people are doing that anymore. And these are novel. These are what kind of breathe life into the field. So I think it's important, as you say, Salim, to really push people to do more, to be creative, to be innovative. You're certainly an example of that with the Abdul-Rauf bypass. That didn't exist in the Yasergil era. Kudos to you and to others like that who are just finding a way to keep it fresh.
Thank you. Any more comments or questions for Professor Lawton? Okay, thank you, Professor. So now we move to our next speaker. Yeah, John?
Oh, thank you very much, Michael.
You're welcome. Thanks for having me.
So our next speaker is Professor John Luis Gomez Alantor from Mexico. He's a renowned skull base and neurovascular surgeon. Professor Aleman, floor is yours.
Okay, thank you very much, Professor Bhatti, for your collaboration. Thank you to Samer and Moshi Hassan for this great effort to honor one of the greatest minds in neurosurgery and to put together all these great neurosurgeons around the world who are part of this memorial for Professor Yasergil. I think that I can say that Professor Yasergil gave us the proper understanding of the 3D anatomy with common sense and courage to perform all the necessary maneuvers that you need to do to perform a successful surgery. Concerning intracranial aneurysms, there are multiple intracranial aneurysms in 7 to 34% of the cases. And of those cases, 20 to 40% are bilateral intracranial aneurysms. So, the learning process that I lived with Professor Yasergil was very interesting. The first thing was to study the books, then go to the laboratory, go to the OR, and then after that, he used to perform a careful analysis of the surgery or the practice in the laboratory so we can learn properly the essence of the surgical procedure that he was performing in some instance. So he was always diligent. He was always teaching people. He was very able to teach in the laboratory, to teach in the conference room. And with all this knowledge, he gave us the tools to perform the precise surgeries as Professor Abdul-Rauf, Arturo Ayala, Professor Lawton presented already, that are quite exquisite surgeries in order to improve the patient's health. In the laboratory, we came to understand the sylvian fissure with all its components and how to dissect the sylvian fissure, but also the contralateral sylvian fissure. Professor Yasergil used to say that the natural corridor to access some brain lesion was to access through the cisterns, to open widely the cisterns and the fissures so you can get to the most deep structures that you can find in some pathology. And most importantly, he always used the microscope with the mouse switch, and he was like dancing around the head of a patient. This allows the surgeon to have the precise and exact position of the pathology in front of the axial view of the microscope. So the microscope is a dynamic tool that you can use wherever you want to perform a surgery. In 1984, the book of Microneurosurgery, the volume number 2, was published. And in that book, Professor Yasergil described by the first time the bilateral clipping of MCA aneurysms using a unilateral approach. In his case, he came through a right trional approach to treat a contralateral MCA aneurysm and then coming back to treat the ipsilateral aneurysm in a patient with a BP shunt, as you can see in the X-ray here. After that, I asked to him, Professor, is it possible to do all the time? And he said to me, Dr. Alves de Souza in Brazil is having quite a good number of cases. And I learned that Professor Pernesky was doing some cases for paraclinoid intracranial aneurysms, and also Professor Yuga Ernest Nimi. We have quite an important series of contralateral aneurysms, most of them treated in the MCA bifurcation, and they coexist with some other aneurysms located in the basilar artery, distal anterior cerebral artery, ACOM, and also ipsilateral aneurysms located in the MCA and the internal carotid artery. It is important that the craniotomy that you are going to use preferably must to be used in the ipsilateral side to the subarachnoid hemorrhage, and also, if possible, ipsilateral to the more complex aneurysm. We employ the pterygium approach in 29 cases, orbitocranial and mini-orbitocranial approach in 9 cases, and mini-pterygium approach in 15 cases. There are some surgical considerations important to address. The coagulation of the contralateral MCA aneurysm and its base was performed in 3 cases, transitory clipping of the contralateral MCA in 4 cases, pharmacological circulatory arrest in 2 cases, and the morbidity associated to the contralateral clipping was in 1 case with transient hemiparesis due to a transoperative rupture. There were no mortality associated to the contralateral clipping in this series. As you can see here, we were able to perform contralateral clipping, transitory clipping of the MCA in 4 cases, coagulation of the contralateral aneurysm and its base, as Professor Abdulrauf described very well the technique of Professor Yasergil to treat an intracranial aneurysm in 3 cases, the pharmacology circulatory arrest in 2 cases, and the morbid mortality that I described before. We need to assess the adequate clipping in the contralateral side. So we use the endoscopic contralateral exploration in 6 cases, and for MCA in 7 cases, and PCOM in 2 cases, and anterior choroidal in 1 case. We have the privilege to perform interpretive angiogram in the OR in 1 case, and in 4 of our cases, we're performing the hybrid suite to have a 3D interpretive angiogram. And we use the sodium fluorescein, which is very cheap in our country, to treat 10 cases to assess the adequate clipping of the contralateral aneurysm. There was intraoperative rupture in the contralateral side in 1 MCA aneurysm. We have 1 case with hyposmia and 1 case with transitory right nasal hemianopsia. So concerning to the contralateral treatment of a paraclinoid internal carotid aneurysm, it is important that there should be a wide dissection of the basal systems, identification of the contralateral corridor, or even drilling the contralateral tuberculum celle in order to perform the opening of the falciform ligament and the dissection of the dural rings. Here I present a case with a bilateral paraclinoid intracranial aneurysms associated with a pituitary adenoma who through a right trional approach, we were able to perform the resection of the adenoma and clipping of both aneurysms. This is another case, a female of 47 years old with subarachnoid hemorrhage. After careful dissection of the systems, as you can see here, we were able to come to the tuberculum cella, and then we perform a drilling of the tuberculum cella to reach the contralateral ventral portion of the internal carotid artery in the paraclinoid segment, identifying the aneurysm, and we were able to clip the contralateral aneurysm with no difficulty in a straight vision and according to the principles of the treatment of an intracranial aneurysm. And then we came to the ipsilateral side to treat the MCA aneurysm and also the contralateral MCA aneurysm, as you can see here in the postoperative angio-CT. This was possible to perform due to a wide dissection of the basal systems. For the MCA, it is important that after the wide dissection of the basal systems, we open the lamina terminalis to relax the brain by releasing the CSF, and then open the contralateral fissure. Here we are applying a fenestrated clip for an M1 segment of the contralateral MCA, being able to preserve the early temporal trunk. It is important to open the interopercular sulci and dissection of the vallecula to achieve adequate exposure for these cases. This is another case, bilateral aneurysms, the ipsilateral located in the ventral paraclinoid in the left internal carotid artery, and the contralateral in the right MCA bifurcation. Here you see the steps of the careful dissection using always the bipolar forceps designed by Professor Yasergil. Here applying the first clip and performing an intraoperative angiogram to assess adequate clipping of the aneurysm. And then we came back to treat this ventral internal carotid artery using a fenestrated clip and under the direct vision using this technique that we call the road mapping clipping technique in order to address a careful and adequate clipping of the aneurysm in the hybrid OR. This is another case in a patient with a left PCOM and right MCA bifurcation aneurysm treated also with the unilateral approach. As you can see here, the position of the clips going from the one side, from the left to the right MCA, that aneurysm that was already clipped in a successful manner. There are some other cases in which we have multiple intracranial aneurysms, in this case, an anterior communicating artery aneurysm, and incidental aneurysms located in the left basilar SCA and the right MCA treated successfully using also endoscopic assisted microsurgery. This is another case, bilateral MCA aneurysms. After clipping the left MCA bifurcation aneurysm, we came to the right sylvian fissure. We dissect properly the M1 segment, and we apply a fenestrated clip that is allowing to have the permeability of the early temporal trunk. And as you can see here in the endoscopic exploration, the M1 trunk is widely open, occlusion of the aneurysm, and the preservation of the early temporal trunk, assessed with direct vision with the endoscope. This is another case, multiple intracranial aneurysms, the same history. After careful dissection of the pterional region, taking out the anterior clinoid process and opening of the basal systems, we came to open the contralateral sylvian fissure and exposing this MCA aneurysm, performing the direct clipping under the vision of a microscope, and then performing an endoscopic exploration to assess adequate clipping of the aneurysm. After that, we came to treat the anterior communicating artery aneurysm and also the aneurysms located in the right PCOM and the right MCA in the M1 segment. The use of fluorescein is very cheap in Mexico. It's about $10 per patient. So we are using this in order to assess complete clipping of the contralateral aneurysm. As you can see here, wide opening of the contralateral sylvian fissure, relaxing the brain, allowing us to identify properly the contralateral M1 and the bifurcation of the MCA, located in the first lobule of this multilobulated aneurysm. And in the inferior portion, facing the insula, we face this small aneurysm located also there. So we perform the clipping of both aneurysms using mini clips in a straight position. This is the bifurcation. We apply the clip. And after that, we need to know that there is adequate clipping with permeability of the contralateral vessels. So we infuse sodium fluorescein, and as you can see here, there is complete permeability of the vascular tree in the contralateral side. And we were able to identify properly the lenticular straits before the clips in the contralateral MCA complex. This is the postoperative angio-CT showing complete occlusion of the aneurysm, and the patient went well. This is another case, very similar to the previous one, bilateral MCA aneurysms, the same history, opening widely the basal systems, relaxing the brain by opening the lamina terminalis and the contralateral sylvian fissure, identifying the contralateral aneurysm, applying the clip, and then infusing sodium fluorescein to assess the complete permeability of the vessels. In this particular case, the patient had also an incidental anterior communicating artery aneurysm, which is clipped in the usual manner, and then we came to the ipsilateral aneurysm located in the left MCA. You can see in the postoperative angio-CT complete occlusion of the 3 aneurysms with no complication. This is a reconstruction for this patient. And there is a special issue concerning the contralateral PCOM aneurysms. It is a topic that is not usually addressed by the literature, but we had this patient with bilateral PCOM aneurysm, and then we make wide dissection of vessel cisterns, and there are several corridors to treat the contralateral PCOM aneurysm: the medial preoptic corridor and the retrocarotid corridor. In this patient, we were able to perform a complete occlusion of both aneurysms using a left orbitocranial approach. This is another case, a patient with bilateral PCOM intracranial aneurysms. So the reconstruction of the angio shows both aneurysms located in the PCOM segment. So we opened widely the basal cisterns, and with careful analysis of the anatomy of the entrance of the optic nerve and the emergence of the internal carotid artery, we need to perform careful inspection of the contralateral internal carotid artery. Not all the time it is possible to perform the contralateral clipping of a PCOM aneurysm, but in this case, with careful dissection and mobilization of internal carotid artery under the optic nerve, we are able to identify the contralateral PCOM aneurysm. Obviously, first we face the PCOM artery, and then we face the intracranial aneurysm located in the PCOM segment. So for this case, we perform a left transclinoidal arterial approach, releasing the contralateral internal carotid artery, and trying to identify the position of anterior choroidal artery. Then, with the careful dissection and releasing of the arynoid structures, we induce adenosine circulatory arrest, and we perform the clip of the aneurysm using a fenestrated clip that saves the origin of the PCOM and also preserves the anterior choroidal artery. In this way, we are able to perform the contralateral treatment of the PCOM aneurysm with minimal mobilization of the optic nerve, and after careful inspection, we need to address that there is no residual aneurysm. For this purpose, we apply a second fenestrated straight clip to perform complete occlusion of the contralateral aneurysm. And then after performing this, we came back to the left side and perform the proper clipping of the ipsilateral aneurysm. As you can see here in the postoperative CTA, we are able to identify complete occlusion of the contralateral and the ipsilateral aneurysm. In the ipsilateral, we use just a straight regular clip, and the contralateral with 2 fenestrated clips, as you can see here. This is another case for bilateral PCOM aneurysm, in which after the identification of the aneurysms, we took the patient to the OR, we performed the wide dissection of the contralateral corridor, we performed a direct clipping under direct vision of the microscope, treating the ipsilateral aneurysm as well, using the left pterygium approach. And then, after careful dissection, performing both clippings, and introducing the endoscope to assess the adequate clipping of both aneurysms, as we can see in the postoperative angiogram that I will show you a few seconds from now. So in this, we see the bilateral clipping of aneurysms with good outcome for the patient. I think there are some advantages to use this approach. Is one surgical event, one anesthetic event, one craniotomy, less manipulation of the soft tissues, and also less brain manipulation if the conditions are adequate to perform such a dissection. There is need to have experience of the team and take notice that there is a narrow and deep surgical corridors and that we need to assess the proximal and distal vascular control to perform these kind of dissections. I think that we need to have a special algorithm to treat these patients with the rupture risk criteria, preferably no giant aneurysms, when a patient with a good Honda-Hess grade, optimal surgical conditions with a relaxed brains, accessible anatomy for vascular exploration, if it's possible with no comorbidity, and experience of the surgeon and the neuroanesthesiologist. I think that multiple intracranial aneurysms are found in up to 20% of the cases. The treatment with the unilateral craniotomy is factible if the conditions are according. The proper clipping should be addressed with endoscopy, fluorescence, or in the hybrid OR performing interpretive angiogram in selected cases. It is important that the individual clinical judgment is crucial to use this technique for these cases. I had experience to learn many things from Professor Yasergil. He gave me the access to his office and his video collection, and I think that it is time to say, after all this experience, thank you, dear professor, and thank you for all your attention. Thank you.
Thank you, Professor Luis. Wonderful. Any question? Any comments, please?
It's a dead group, Juan. We're at the end of a long day.
Yeah, I know.
But thank you very much for presenting.
Really a marathon.
Thank you all for joining us today. It was a long day. Stayed for about 15 hours. And I'd like to appreciate the effort done by Professor Ata Al-Hati for moderating all the time, most of the time, and for John Bennett for being here all the time. Thank you all.
Thank you.
Thank you all.
Thank you, Professor.
Okay, we're signing off now. I've got to go on.
This is the end of the day.
I've got another conference to go to in Ecuador. Thanks,
Thank
everybody.
you. Thank you.
We'll talk to you. Great job, Sam.
Congratulations for all.
You put together a great cast.
Yeah.
Bye.
Thank you.
Congratulations.